So, hey, good morning. Good morning. Oh, great, great, excellent. So, hey, it's an exciting time for us to be here. It's really great to have the OREF Mid-Atlantic Resident Research Symposium here at the University of Pittsburgh. This actually is an exciting time. It is a first step. It is essentially, as many of you have heard me say, respecting the past and embracing and shaping our future. The last time and the first time we had actually partnered with OREF for the Resident Symposium was actually back in 2016. Dr. Fu was the chair at that time. I was the Associate Residency Program Director, and we held this event down the hill at one of the older hotels, essentially in the dinner and reception area. And it was a great time then as well. I remember our keynote speaker was Chef Hurwitz, and Leah and others may remember that. And Vince Dini was still the program director, and it was an exciting time with he and Rocky Twine serving as our judges. But we've really advanced forward. We now have a great partnership between the Department of Orthopedic Surgery and OREF, amplified by our new Bethel Musculoskeletal Research Center under the direction of Dr. June Lee here with us. And so for all of those who are visiting from other programs, thank you for taking the time from your schedule. Thank you to your chairs and program directors for giving me the opportunity to come and visit with us. We're really excited about the research talks that will be given today. A few things, Mr. Lee Grossman will come up and give his overview of OREF. Just a few brief housekeeping things. We have our four judges who are here, who are Dr. James Wong, our Vice Chair of Research, Dr. Albert Lin, our Program Director and Vice Chair of Education, Dr. June Lee, our Bethel Professor and also Director of the Bethel Musculoskeletal Research Center, and also Dr. Christian Latterman, the Chief of Sports Medicine at MGH Brigham, and also an alumnus of our orthopedic training program here at Pitt. And so without further ado, I will invite Lee Grossman up, who serves as the Chief Executive Officer of the OREF, and look forward to a great day, and thank you again for being here. Lee.
Good morning, everyone. It's fantastic to be here in Pittsburgh. Couple things. I'm going to take care of some housekeeping issues before I get into my remarks about OREF. First of all, when you come up here, you're going to find a folder that is broken down by sessions. You click on the session, and then your talk should be in there, and then open that up. And hopefully that makes sense. I know it's difficult when a boomer is trying to explain things to millennials and younger. And I hope I didn't become a meme in doing this, because my challenge is getting my own slides up here. Let's see if I can make that work without embarrassing myself too much. All right. Good. If I can do that, I'm sure everybody else can. So after you finish your presentation, please park yourself close to the front here, because there'll be the Q&A, and when the Q&A part starts after everybody presents in that session, please stand up here, come to the microphone when the judges ask you a question. We're recording all this, so we want to make sure that we capture everything on the microphone. All of the presenters, you've received scoring sheets today. And that's to rate your fellow presenters. At the end of the day, that person with the highest score will receive a cash prize, as well as the Presenter's Choice Award, which is very prestigious. The top three presenters today will be invited to present their work at the OREF National Resident Symposium. That's going to be in November. That's going to be held virtually. And you'll be competing against the other regional winners. The grand champion of the national gets an all-expense paid trip to the academy, the AAOS meeting in New Orleans this coming next March. And lastly, please, after every session, you'll find Carmen, who will be walking around here. She's not in here now. Please give her your scoring sheets. Thank you. So with that, this is really a great thrill for me to be here. I'm from this area. My parents My siblings, we were all born in Pittsburgh. I was raised in Fayette County. I'm one of the survivors to get out of there. We're lifetime Pirates and Steelers fans, and it's just great for me to be here today. My sister, who's here, we were trying to figure out where we were born. It was either Mercy or Montefiore back in the day, but it's really, really, truly wonderful for me to be here. With that said, on behalf of the Board of Trustees of OREF and myself, it really is a true honor and pleasure for me to be here and for us to be presenting and hosting this with the University of Pittsburgh. This is the second of our series of Resident Research Symposia that we're doing this year. This year we have 5. We're doing, a couple weeks ago, we're at the University of Miami. We're here at Pitt. In the fall, we're doing UC San Francisco, Hospital for Special Surgery, and we'll probably be doing also the University of Chicago. And then following that in November will be the National Resident Symposium. So thank you for doing this. We've been putting on the Resident Research Symposia for 23 years now, and it really is a signature event of OREF. Have to start out by thanking all of so many people. Mac for hosting this today, our keynote speaker, Dr. Latterman. Our judges today are Dr. Latterman, Dr. Lee, Dr. Lin, and Dr. Wong. They'll be the people asking you the questions. If there's time, we'll probably open it up for those of you in the audience to also ask questions during the Q&A. And also, we really need to thank our sponsors. Without their help, without their support, we wouldn't be able to put these programs on. And we're very grateful to J&J, Zimmer Biomeds, and Smith & Nephew, as well as the Hark family. It's a foundation that has been very generous in supporting our educational programs as well as our resident symposia. So, you know, what is OREF? It seems like everybody knows, has heard of us, but very few people know what we do. I've been in the nonprofit space for, over 20 years now. I was in the orthopedic industry for over 20 years before getting into nonprofits. And I've been associated with many nonprofits. I am here to tell you that there are very few, if any, nonprofits that I've been associated with and have dealt with that have the same impact and significance in forwarding their mission than OREF does. We've been around for 70 years. We are independently funded. That independence gives us the tremendous opportunity to pursue what is the greatest need in MSK research at that time. We don't have to respond to members or industry or other special interests. We're pursuing what the orthopedic surgeons and that community defines as what our greatest needs are. So that is one huge advantage we have. And as a result of that, our peer review process is stellar because, again, we have that independence and we can prioritize where the greatest needs are regardless of the specialty area. Last year we awarded about $1.2 million in grants. That was about $6.9 million. Our portfolio right now at any one time is approximately 100 grants that we're actively managing with what I'll call a street value of about $8 million. And one of the greatest parts of our mission is, and why we were founded, was to feed the pipeline for new investigators, and that's why the symposia is so important. It generates interest and encourages people to pursue clinical research as part of their career. And we see ourselves as, because we're independent and because we represent all aspects of MSK, we see ourselves very much as a unifying force in orthopedics. This pie chart is an example of, over the last 5 years, what we funded. If you look at it, you'll see that we have, for all intents and purposes, funded every aspect of MSK research, and this pie chart is dynamic as well. Some years, a couple years ago, trauma was the number one. And again, it represents where the community decides the priorities for money should be placed. We are 100% donor supported. Again, that provides us with this independence that we can pursue the best research that's possible. And this is the institutes that, these are the medical centers that support our mission through department gifts, and I'm very happy to see that University of Pittsburgh is on there, and they've been participants for many, many, many years, and we cannot be more thankful to them in doing that. Our impact has been well documented. There's been a study that's been published in JBJS recently, last year, that showed that approximately 20% of the grants that we fund go on to receive greater funding from foundations and or the federal government. So when to think that you get a grant from us, you have a 1 in 5 chance of going on to get greater funding, that's incredibly impressive. Our career development grants, about 50% of those go on just to receive much more funding as well, at an average about 7 times what the initial grant was. The increase in publications has been well documented as well. Again, because we're prioritizing, we're pursuing the best science that's out there, the tendency for that to go on to be published in a high-impact journal is very high with the OREF grants. Other work has been shown that those that get OREF grants, 64% of them go on to pursue academic careers, which is a very high percentage. And then, was it 2 weeks ago? An abstract came out for what's going to be published soon in JOR, showing, and this is very pertinent to today, that 42% of the regional winners in our Resident Research Symposia go on to pursue academic careers. And 77% of those regional winners also were published in high-impact reviewed journals. When you look at our impact, we have funded about $150 million in grants, 4,700 grants as well, and many of those initial funded grants have gone on to change the practice of orthopedics. This is a very small sampling of some of the research that we funded at its earliest stages that went on to change the career practice and is being applied today in your training and in your practice. Now, to get a little bit more serious and to talk about where we are today in terms of MSK research, about 18, 20 months ago, we began talking openly and publicly about the crisis that exists in MSK research. And there's an incredible disconnect between the burden of disease in MSK, which dominates healthcare. It's 5%. It's 5% of GDP. It's almost $1 trillion a year of monies that's spent on the burden of disease in MSK. And yet, we're among the least funded of all medical specialties. I'm the co-chair of the NIAMS Coalition. I deal with NIAMS all the time, and they're the 4th smallest funded institute. And at that time, we identified the areas of greatest need and the consequences of this burden, or of this huge dichotomy between burden of disease and the amount of funding, and the consequences that may come out of that, which are somewhat dire. Well, in the last 3 months, that crisis is, for the most part, gone towards on steroids, where some of the funding that we have had established long-term, like, for example, the Congressional Directed Medical Research Program, I was on the programmatic review of one of those, that money is gone. The orthopedic peer review, that money is gone. CDC surveillance on arthritis is gone. We expect the HHS budget to drop today, the proposed budget, and it should show about a 40% cut in NIH and maybe the disappearance or suggested disappearance of NIAMS being rolled up into another institute. So as Mac presented at the beginning where he said that Pitt focuses on, embraces the past but focuses on the future. That's where OREF is now. We're pivoting. How do we address this crisis? How do we bring the community together? One of the hallmarks of OREF, one of our greatest highlights and what we're most proud of is our collaboration. We collaborate with over 60 organizations. For us to get through this, for us to fund and put the efforts into what is needed to address that huge dichotomy in MSK research, and the fact that our nation's healthcare cannot improve without increased funding for MSK research, is that we're going to be drawing on this collaborative effort with all of our orthopedic and MSK partners to find ways and more creative ways, more innovative ways that we can fund future research. And do it in a way that's perhaps much more cost-effective and certainly focusing on what will provide the greatest clinical impact in the shortest amount of time. Part of doing that is that we need more funding, obviously. For the residents here, we partner with Medacta, for example, to provide you with the opportunity by just donating $25 to us that you'll be part of the OREF community. And we've been working with departments that fund those for the residents as well. And it really is all of you in this room. It's our supporters that really make the difference in what we're doing, not only at OREF, but addressing MSK research. And we're here, we're very grateful to be here, and we're also hoping that you'll support really the only orthopedic organization committed solely to funding research in all subspecialties and improving clinical practice and patient outcomes. For all of you that are presenting today, good luck. Thank you for being here, and it's an honor for us to be here. Thank you.
All right. For those of you who don't know me, I'm Albert Lamb. I'm the program director here at Pitt. I think it's a great honor to be hosting this event and also to have all the residents here from our institutions here in the Mid-Atlantic. So really looking forward to that. Lee, thank you. And thank you to OREF, and Christian, thanks for being here, and our industry partners as well. So my distinct pleasure to kick it off with our first session here, which is the sports and biomechanics. And look forward to all the sessions here from our future orthopedic leaders here. So the first presentation will be Julia Retzky from HSS. She's going to talk about early ACL mitigates the development of post-traumatic osteoarthritis in a murine ACL rupture model.
Thanks, Dr. Lynn. Good morning, everyone. My name is Julia Retzky, and I'll be presenting our project looking at the impact of the timing of ACL reconstruction on the development of post-traumatic osteoarthritis using a mouse model. So it's well known that up to 60% of patients develop post-traumatic osteoarthritis, or PTOA, at an average of 10 to 25 years following ACL reconstruction. And although some studies suggest that early reconstruction may mitigate PTOA, others have found no difference in the timing of surgery and the development of arthritis. Therefore, the optimal timing of ACL reconstruction in order to mitigate PTOA has not yet been fully elucidated. And in addition, the impact of both the local and the systemic immune cells on the development of PTOA has not yet been determined. Our primary aim was to evaluate the impact of the timing of ACL reconstruction on the development of PTOA using a non-invasive or closed ACL rupture model. Our secondary aim was to evaluate the impact of the timing of reconstruction on pain-related gait behaviors, both the peripheral and central immune and inflammatory response, knee range of motion, and tendon graft to bone tunnel healing. 55 11 to 12-week-old male black 6 mice were randomized to one of 3 conditions: either an ACL rupture only, ACL rupture followed by immediate ACL reconstruction, or ACL rupture followed by delayed ACL reconstruction at 7 days post-injury. We also had an uninjured control group included in our analysis. Mice in the immediate and the delayed reconstruction groups were sacrificed at 28 days post-surgery, and mice in the ACL rupture only group were sacrificed at 28 days post-injury. Our primary outcome measure was a histological evaluation of osteoarthritis using the OREF scoring system. Our secondary outcome measures included evaluation of knee range of motion, analysis of local and systemic immune cells using flow cytometry, gait analysis, and quantification of bone formation at both the femoral and tibial tunnels using micro-CT. In order to rupture the ACL, our mice are anesthetized and placed prone. The knee is flexed to 90 degrees, and the ipsilateral ankle is secured with a secure ankle holder. An axial load between 5 and 20 newtons is applied to the distal tibia at a speed of 1 millimeter per second in order to rupture the ACL. Successful rupture is confirmed by a positive Lockman test. Moving on to our results, we found worse PTOA at 28 days postoperative in the delayed ACL reconstruction group compared to the immediate ACL reconstruction group. Specifically, we found higher femoral and tibial OREF scores in both the delayed reconstruction group and the ACL rupture only groups compared to the immediate reconstruction and the control group. By contrast, the immediate ACL reconstruction group had similar femoral and tibial OREF scores compared to the uninjured control group. These are just a couple representative histologic images, again demonstrating worse osteoarthritis in the delayed reconstruction and the ACL rupture only groups compared to the immediate reconstruction and uninjured control groups. Moving on to range of motion, we found that the delayed reconstruction group experienced persistent stiffness at both 14 and 28 days postoperative. And while the immediate reconstruction group initially experienced stiffness at the 14-day time point, by 28 days, they were able to regain their motion similar to that of the uninjured controls. We found no difference in pain-related gait behaviors between groups at any time point. Specifically, we found no difference in the time and swing phase, time and stance phase, stride frequency, gait symmetry, and paw area peak stance between groups at any time point. To identify the lymph node that drains the knee joint, a separate cohort of mice underwent intra-articular Evans blue dye injection. We found that the ipsilateral iliac lymph node and its associated afferent and efferent vessels retained Evans blue dye following the injection. Therefore, we used the ipsilateral iliac lymph node as a readout of the local immune response and the spleen as a readout of the systemic immune response. We found an increase in total iliac lymph node cellularity, but not spleen cellularity in both surgical cohorts compared to the ACL rupture and the control group. There was no difference in bone formation at the graft bone interface or bone mineral density of the tibial and femoral tunnels between the immediate and delayed reconstruction groups. And these are just a couple representative micro-CT images showing bone formation at the femoral and tibial tunnels. So in conclusion, we found that immediate ACL reconstruction mitigates the development of PTOA in a murine closed ACL rupture model. The ipsilateral iliac lymph node reflects the local inflammatory environment, and chronic unresolved inflammation may lead to progressive PTOA. Although future studies aimed at elucidating the role of reconstruction timing and inflammation on the development of PTOA will allow us to better address this very common and detrimental sequelae of ACL injuries. In terms of limitations for this study, we only used male mice, and all of our surgeries were done open, as arthroscopic surgery is not possible in mice. So I'd like to thank all my co-authors for their support and guidance over the last 3 years that we've been working on this project, and thanks to the OREF for the opportunity to present today. That's it.
Excellent. Thanks so much, Julia. Our next speaker is Zachary Herman from our very own UPMC. He's going to talk about overhead athletes have comparable intraoperative injury patterns and clinical outcomes to non-overhead athletes following cervical stabilization for first-time anterior shoulder instability at average 6-year follow-up.
Good morning, everyone. I'm Zach Herman. As Dr. Lynn said, I'm one of the residents here. I'll be presenting our work on clinical outcomes of overhead versus non-overhead athletes following shoulder stabilization surgery. I'd like to thank my co-authors, many of whom are here today, for their hard work and for coming today. Oftentimes, anterior shoulder instability presents in non-overhead contact athletes after traumatic events in the form of dislocation. Overhead non-contact athletes are more likely to present with subtle instability, secondary to repetitive microtrauma in the form of subluxation events. Previous research has shown overhead athletes and throwers with superior capsulolabral pathology have decreased return to sport rates and increased complication and revision rates when compared to non-overhead athletes after surgical intervention. It remains unclear, however, though, how participation in overhead sports should affect algorithms for the treatment of first-time anterior shoulder instability events. As such, the purpose of the study was to evaluate the clinical presentation, outcomes, and recurrence and revision stabilization rates of overhead versus non-overhead athletes following stabilization after first-time instability episodes. We hypothesized that overhead athletes would have milder clinical presentations, similar surgical characteristics, and diminished postoperative outcomes when compared to non-overhead athletes. The study was a retrospective review of consecutive patients from 2013 to 2020 at a multi-center regional healthcare system with a minimum of 2-year follow-up. Inclusion criteria included surgically managed patients following first-time anterior shoulder instability episodes, and inclusion criteria were prior stabilization, multidirectional, or recurrent instability. Dislocation was defined as events requiring manual reduction and confirmed with MRI findings such as anterior labral tearing with or without Hill-Sachs lesions. Subluxations were defined as instability events that did not require manual reduction. Overhead sports were required or defined as sports involving lifting above one's head or utilizing a throwing arc of motion. These included baseball and softball, basketball, football, particularly the quarterback position, CrossFit, volleyball, martial arts, rock climbing, and gymnastics, as well as swimming. And lastly, labral tear location was defined using the clock face method. Charts were reviewed for patient clinical presentation data, injury and imaging characteristics, and information on recurrent instability and revision surgery rates. Patients were contacted via surveys to collect patient-reported outcomes, as well as information on returning to sport and returning to work. Our primary outcome of interest was recurrent instability and revision surgery rates. Secondary outcomes of interest were patient-reported outcomes and return to work and return to sport rates. A total of 256 patients were included with a mean age of 23 years. 70% were non-overhead contact athletes. Our results showed that non-overhead athletes were more likely than overhead athletes to present following dislocation. No differences were found in other injury characteristics, including bony injury, labral tear size, or posterior or superior labral pathology. Further results showed that overhead athletes were more likely to undergo arthroscopic procedures as opposed to open procedures, and no differences were found in pre-op range of motion, strength, or intraoperative characteristics such as the total number of anchors used or incidence of slap tear repair between the groups. After survey administration, data on 60 patients with mean follow-up of 6.7 years was available. No difference was found between groups in primary outcome of redislocation rate or revision stabilization. Additionally, no differences were found in secondary outcomes of interest, including various PROs like the ASES score, WOSI, Brophy, and SSV scores. No difference was found when comparing return to work or return to sport rates between the groups. So in all, overhead athletes were more likely to have milder presentations with subluxation events, but no difference in outcomes were found when compared to non-overhead or contact sport athletes following stabilization. Based on the results of our study, we've concluded that overhead athletes can be considered in the same treatment pathway as non-overhead athletes following first-time anterior shoulder instability episodes, with similar outcomes expected. Thank you.
Great, thanks, Zach. Our next speaker is from HSS, Alexandra White. He'll talk to us about the effect of posterior tibial slope on tibiofemoral joint biomechanics and in vitro analysis.
Okay, good morning, and thank you for the opportunity to present our work today. We have no relevant disclosures. So the incidence of ACL reconstruction has more than doubled over the last several decades. Despite this, ACL reconstruction fails at a persistently high rate. increased posterior tibial slope has been identified as one anatomic risk factor for both primary ACL failure and ACL reconstruction failure. And several studies have demonstrated biomechanically that high posterior tibial slope increases forces across the ACL and increases anterior tibial translation. High tibial osteotomies have historically been performed to correct limb alignment in the coronal plane. However, slope-reducing osteotomies have gained popularity as a sagittal plane correction to reduce the risk of ACL failure in the appropriate patient. And while most of these slope-reducing osteotomies are performed in the revision setting, a portion have been done in the primary setting with positive clinical results thus far. So the existing literature on tibiofemoral contact mechanics after sagittal plane osteotomies is limited. While there is some canine literature and mixed human studies on the topic, based on our review, no study has investigated both medial and lateral compartment tibiofemoral contact mechanics after pure sagittal plane osteotomies. So with that, the purpose of our study was to quantify the effects of increased and decreased posterior tibial slope on tibial plateau contact mechanics using human cadaveric knees during knee flexion with axial loads. Informed by our pilot studies, we hypothesized that increased posterior tibial slope would result in a posterior translation of the weighted center of contact on the tibia in the lateral compartment, whereas decreased posterior tibial slope would result in an anterior translation of the weighted center of contact in the lateral compartment. We also hypothesized that peak contact stresses would remain unchanged for both the increased and decreased slope conditions. So our study included 8 human cadaveric knees with intact cruciate and collateral ligaments. We tested 3 conditions: an intact state, a 7-degree opening wedge state, and a 7-degree closing wedge state. Osteotomies were performed using a freehand supratubercle technique and were fixed using bone staples. The opening wedge condition was kept open using a 7-degree PMMA cement wedge, and specimens were included if they had a native slope in the range of 7 to 11 degrees. The knees were potted in custom fixtures, and a TechScan electronic pressure sensor was attached across the tibial plateau. For testing, the knees were mounted to the AMTI Vivo joint simulator, and the testing protocol was performed uniformly for each condition and consisted of 500 newtons of axial compression at 0, 15, 30, and 45 degrees of knee flexion. All outcomes were quantified for the medial and lateral compartments and consisted of a tibial weighted center of contact and peak contact stress as measured through the TechScan sensor, which you can see shown here. The following table demonstrates the anterior and posterior translation in the weighted center of contact for each osteotomy state compared to the intact condition. The most immediate takeaway is that the greatest magnitude of anterior-posterior change occurs in the lateral compartment for both osteotomies. And at all tested flexion angles, the closing wedge produced a statistically significant anterior shift in the center of contact in the lateral compartment compared to the opening wedge. Here's a representative pressure map of the lateral compartment in a single knee, where the opening wedge osteotomy shifts the center of contact posteriorly, and the closing wedge osteotomy shifts the center of contact anteriorly. Meanwhile, when we look at the medial compartment, the weighted center of contact for all 3 conditions remains relatively unchanged. And so when we look at peak contact stresses under axial loading, there were some noticeable trends. However, the only statistically significant difference was noted at 30 degrees of flexion in the lateral compartment, where pressures were greater in the decreased slope state compared to the increased slope state. So in conclusion, we found that increased tibial slope results in a posterior translation in the center of contact on the tibia in the lateral compartment, and that decreased tibial slope results in an anterior translation in the center of contact in the lateral compartment. There was a significant increase in peak contact stresses in the lateral compartment alone at 30 degrees of knee flexion in the decreased slope state, but there were no other significant changes in peak contact stresses. And finally, this study is the first of its kind to assess tibiofemoral joint biomechanics after isolated tibial sagittal plane osteotomies, and with the incidence of post-traumatic OA following ACL reconstruction upwards of 43% at 10 years, further research should investigate the long-term implications of these procedures at the joint level. So thank you, and I'd like to thank my co-investigators, in particular PIs Dr. Suzanne Marr and Anil Ranawat for their guidance to this project. Thank you.
All right, thanks so much, Alex. Our next speaker is Lutz from the University of Maryland. She's going to talk about the impact of obesity on PROs 2 years after a multi-ligament knee reconstruction.
Alrighty, good morning, everybody. I am Lutz from the University of Maryland. Thanks for having us down here today. So I'm presenting looking at multiligamentous knee reconstructions in obese patients. We have no disclosures. So obesity is a risk factor for a lot of the surgeries and a lot of the procedures we do, but this has not been well documented, at least for multiligamentous injuries and multi-leg reconstructions. Thankfully, these are uncommon injuries because they are fairly devastating, but we do know that multi-legs have poor outcomes and high complication rates, so it's a population worth looking into. So the purpose was to look at the relationship between obesity and 2-year or long-term patient-reported outcomes after a multi-leg reconstruction. So we prospectively enrolled patients from January to March of 2019 to 2022. We pulled a lot of different patient-reported outcomes. The big ones that we looked at were PROMIS. PROMIS has physical function, pain interference, fatigue, social satisfaction, and then the IKDC, which is another questionnaire that looks at kind of a combination of pain and function. And then the NPS, numeric pain scale, which we all use every day, and then a few other ones like MODEMS and Tegner to look at activity level. So we did a bivariate analysis. We split it into 2 groups. BMI over 30 was considered obese. BMI less than 30 was non-obese. So out of our 38 patients that were eligible, 71% did complete the 2-year surveys and the patient-reported outcomes, which anybody who's done survey work knows that that's pretty good, actually. 2 years after you operate on somebody to get them to answer their email. The socio-demographic factors between the 2 groups was similarly distributed, so no co-founders that we expected to see there. Something that we did take note of is we looked at all the op notes, all the surgical reports from these cases, and in 47% of the obese patients, there was cartilage damage just noted on the operative report, as opposed to only 8% or one of the patients who was considered non-obese did the operative note mention any cartilage damage. So here are our results. Bear with me. I know it's a little overwhelming, especially on that big screen. But basically what we found is there were significant differences between baseline for obese and non-obese patients, and baseline in this study is considered post-injury, pre-surgery, rather than pre-injury, a true, what you would think of as a true baseline. But post-injury, obese patients tend to have worse physical function, worse pain, worse fatigue, and worse social satisfaction. Interestingly, anxiety and depression, it was not significantly different between the 2 groups. And then if we move over to the right side, for both baseline and 2-year data between obese and non-obese patients, they were significant in the IKDC, which again is a measure of pain and function. And then numeric pain scale of both operative knee and whole body was significantly different at 2 years between the 2 groups. So in conclusion, this tells us a couple things. So obesity certainly had a greater incidence of cartilage damage, at least as noted intraoperatively in the op notes in our cohort. Obesity also was a predictor of worse baseline for PROMIS physical function, for pain, fatigue, and social satisfaction. And then it also extended to 2 years that obesity was associated with worse IKDC, NPS for both operative knee and the entire body. And we know from previous research, we know well that post-traumatic arthritis has increased rates in obese patients after multi-legs. So this may be what's contributing to the worsening pain that we're seeing. So I think the take home here is obese patients tend to have increased pain after multi-leg reconstruction. This continues for up to at least we know 2 years. The existing cartilage damage that they do have when we go in there and we do these surgeries, and the increased joint forces from their heavier BMI may be what's expediting this post-traumatic arthritic pain. And I think all this is to say we need to counsel our patients appropriately. If you have a patient who has an elevated BMI and is undergoing a multi-leg, you need to have a discussion with them that they will probably have worse outcomes and more pain than their low BMI counterparts. And some references, and that's all I have. Thank you, guys.
Excellent. Thanks so much, Ellie. And our last speaker of this session is Elizabeth Clayton, also from our institution at UPMC. She's going to look at a multi-perspective look at secondary school student athletes' access to orthopedic care and athletic training, a preliminary study.
Good morning. Thank you, Dr. Lynn. I'm Elizabeth Clayton, an orthopedic surgery resident here at the University of Pittsburgh Medical Center. Thank you to OREF for this platform to talk about my ongoing research looking at access to orthopedic care and athletic training for secondary school athletes. Before getting started, I would like to take the time to thank my co-authors, YRAB, the support from community partners, as well as the financial backing of the Health Equity Grant from the Diversity, Equity, and Inclusion Office of the Pittsburgh Children's Hospital. I have no conflicts of interest to disclose. From 2021 to 2022, around 7.6 million high school students participated in athletics, putting this population at an increased risk for sports-related injuries relative to their counterparts. Access to appropriate medical care, particularly orthopedic care, can be influenced by socioeconomic status. Studies show that individuals from lower socioeconomic status backgrounds often experience greater challenges when securing orthopedic physician appointments due to insurance limitations and other financial constraints. It is known that there is a relationship between socioeconomic status and access to athletic training and orthopedic care among high school student athletes, with athletes from lower socioeconomic status having less access to both athletic trainers and orthopedic care. And so there is a notable gap within the literature regarding the relationship between socioeconomic status and access to care by exploring the actual individual perspectives of those who are impacted by it, the secondary school athletes as well as athletic trainers. So in order to explore the specific perspectives of secondary school student athletes and those who help to facilitate and give the actual care, the athletic trainers, on their access to orthopedic care and athletic training, we conducted semi-structured interviews with athletes and athletic trainers in the Western Pennsylvania area. Video conferencing was used to conduct the interviews, and the recorded audio was uploaded to a software called Otter.ai for transcription. Using the software in vivo, the transcripts were then analyzed and coded using a mixed approach of both inductive and deductive coding, allowing for the construction of new codes based on the data. And then the codes were then used to identify themes related to access to orthopedic care. So the interview questions that we asked athletes and athletic trainers included questions related to the number of sports that they played or covered, the types of injuries that were commonly experienced, and what happens after an injury occurred. So we interviewed 14 participants, 6 athletic trainers, and 8 athletes from 10 different schools, representing a number of sports. Using in vivo, the interviews were coded and analyzed to identify barriers and facilitators to access to orthopedic care and among the student athletes in Western Pennsylvania. So some of the barriers that we found as it relates to orthopedic care were insurance incompatibility, parental pushback, limited athletic training hours, inconsistencies in concussion protocols, and communication challenges with providers. Factors that facilitated access included favorable insurance coverage, parental involvement, as well as proximity to medical facilities. So this is a preliminary study, and most of these findings are only have been single coded by me. And so the next step would be to, one, utilize more coders in order to potentially eliminate bias, refine the codes as necessary in order to be able to expound upon the themes that have currently been identified. And then 3, we also want to include more interviews with the hope of reaching thematic saturation. So after delineating the themes, we would then be able to meet with the participants in order to collaboratively work with them to identify potential interventions in order to create meaningful relationships and ensure that student athletes who do have less access to orthopedic care are getting the tools, and we're able to come up with policies that will then be able to ensure that there's equitable care for all healthcare opportunities. Thank you.
Thanks so much, Elizabeth. It was great mix of presentation of both basic science and clinical research. So we're gonna ask the presenters to actually come up on stage here. I know there are no seats here, so it feels like a firing squad. But we have about 5 minutes for Q&A, and so I will start. I'll start the Q&A here. And my question is for Ali. So when you're dealing with this population of multi-ligament dislocations, did you guys break this up into etiology? So we know that there's sort of a low energy dislocation versus a high energy like a MVC.
Yeah.
And so how does that play into sort of the results here?
Okay, put on the spot for my future boss. We did not split it up just because this cohort was too small. We only had 38 patients, so I just think we wouldn't have been able to make many conclusions or anything substantial. I will say anecdotally, I feel like we do see a fair number of this low velocity obese patient getting a multi-leg. We certainly get our fair share of, via shock trauma, the high energy as well. So that is something that I would love to look into because I do think it's a completely different injury. I just don't think, thankfully, the numbers are high enough that we can separate it out to understand much unless we did some kind of, multi-site study with it.
Got it. Thank you. Do you guys, Christian?
Ali, while we have you up there, let me ask you the question that I had. So you found on the baseline data, these were mostly kind of social parameters that you were looking at, that there was a significant difference in the obese versus the non-obese. What do you think that translates to in terms of your overall outcomes that you're looking at? I mean, are you comparing apples and oranges here, or why do you think, or what do you think that will lead to in the end? You're starting at different levels, right?
Yeah, it's a good question. I think it's hard to understand all the reasons why these patients don't do as well. I think all we can say is we know that they're having more pain. Is it because of things in their background and risk factors they have versus the injury they have, the load they're putting through the joint? Very hard to say. When I was going through this data, and obviously, most of this is patient-reported, survey-based type thing, I wish we could have better quantified the cartilage damage because I think that in my mind at least, is probably a big pain generator for these patients and has to be, at least in part of what's causing this 2-year pain is that's not acute postoperative period anymore. That's something that's going on in the joint. So for future directions, we could somehow try to grade that or, prospectively enroll patients so that we can better understand the exact cartilage damage, and then hopefully maybe if that's associated with worse pain outcomes in the end, maybe we'll understand that.
One of the big difficulties with obese patients, and we see this in the cartilage repair world quite frequently in patients who undergo weight loss surgery, is that sudden changes in the weight-bearing status for that group of patient affects them a lot more than in normal weight patients. And that's something that you may want to look into. Because they may actually not only have the more severe injury to start, but they may also undergo significantly more rapid changes in the course of the PTOA that they all develop than normal weight patients. And that's something that we see in patients who undergo weight loss surgery, and then two years later, suddenly they start showing up with cartilage damage, not necessarily because they have injuries, but because they are completely differently loading their cartilage that they developed for 40, 50 years.
Yeah, that would be interesting. I don't think our patient population lends to that as well, but that's certainly, maybe a third cohort of comers.
You're off the hook.
It either means I did really well or really terribly. I'm not sure.
My question was actually for Dr. Retzky from HSS. I was looking at your research interestingly because the mouse models are very small.
Yes.
Right. And I'm not a sports person. I'm a spine surgeon. I've done some spine surgeries in mice, and they're really hard. So can you make a comment on like how you reconstructed ACLs in your patients?
Sure.
And they're not bipedal. That's one of the things that we also deal with in spine surgery, working with animal models. So what's your thoughts on just the difference in biomechanics?
Yeah, thank you. Great question. In terms of how we do the surgeries themselves, first we rupture the ACL, and when we're doing the immediate surgery, we harvest FDL autograft. We drill with 23 gauge needle, both of the femoral and tibial tunnels. And in terms of our fixation on the femoral side, we use a vascular clip. And on the tibial side, we use suture fixation. So distal to the exit of our tibial tunnel, we drill a transverse tunnel and then use 4-0 ethibond to tie over the distal aspect of the graft. And we use 5 Newton weight in order to tension the graft and fix with the posterior drawer. In terms of the biomechanics, yeah, that's a great point. Absolutely, there are some differences, and perhaps our mice, given that they're not bipedal, are seeing a different, maybe diminished load compared to what you'd see in a human. But I think that as of now, it's probably our best model in terms of small animal model for looking at ACL reconstruction.
Yeah. One thing we had to do in spine is actually try to motivate the rats or mice to sort of stand up. So we torture them by putting feeding tubes and water bottle up high, which has actually worked relatively well. So
That's a great idea. We'll look into that.
Yeah, I have a question for Julia also. Yeah, it's very impressive work. Okay, I have to confess that's really, really, really good. Okay, now my question to you actually is, although the conclusion I think is very reasonable, because if you delay the ACL reconstruction, you change the biology of the joints, knee joint, and also the biomechanics. So as a combination of these both, and you lead to OA development. We call PTOA, right?
Yeah.
So that's to me is very reasonable, and in your work it's also very comprehensive. I mean, I'm very impressed. I don't know how many people working in your team. Otherwise, it's one.
Yeah, thank you. We have a great team of many people in our lab who have contributed.
So one thing you may be aware of that is, once you rupture the ACL, I suspect you also injured the knee joint as a whole. It's not just ACL, okay? So inflammation is extensive. And then if you operate on this, do the ACL reconstruction, biologically, it's very prone to the infection. Now I'm talking about translation to the humans, to the human patients. If you get a rupture and you do ACL reconstruction right away, you probably get an infection fairly soon. Okay. Do you think that's something you probably need to consider in kind of further study?
In terms of infection risk with
Yeah.
going immediately. So we have considered that, and at both the immediate and the delayed time points, we luckily have had no cases of infection. I will say it is definitely possible, and in other experiments, as an example, we did one round of surgery where we injected corticosteroid at the time of the delayed reconstruction, and all of those mice were infected. So we do see infections, but we didn't see any in this cohort, so I don't think the immediate surgery was a risk factor for future infection. Rather, the corticosteroids were in our other experiment.
Thank you. I think, Mac has tasked me to try to stay on time, but I do want to ask one question to Elizabeth. partly one, because your shoes are slay, right? And, but I did want to ask you, so all these surveys that you've done, I think this is really important work. Are schools that are already linked with like a healthcare provider? Like that there's already a conduit for the athletic trainer to get care for these kids, or these are sort of a mix of schools?
So it's mostly a mix, but the athletes often did attend or go to a school where an athletic trainer is located. I think what makes it a little bit more complicated is that I included middle school athletes within the study who don't have an athletic trainer due to the way that the infrastructure is set up. And I thought that it was important to include them and potentially look at school nurses who would be providing care, but some of the athletic trainers I interviewed were also affiliated with a middle school, or like the high school and middle school were together, and they were able to treat those athletes as well.
Sure. And that's a telling sign if it's still difficult due to healthcare insurances, even if there's a conduit for them to get access to care. So, so thank you so much to this round. You guys did really, really great job. So appreciate the presentations.
Okay, so we'll move on to I think the next section is the trauma section, but just as an introduction, for those of you who are visiting, I'm June Lee. I'm one of the spine surgeons here and also the director of the Bethel MSK Research Center, and we're happy to sponsor this. OREF is such a great foundation. Both myself, I know Dr. Hogan's been a beneficiary of it. We were recipients of the $5,000 Resident Award when we started. When I was in Johnny Huar's lab, so happy to get that award. And that may be part of the reason why I'm standing here today. You never know. But happy to be part of this, happy to be sponsoring this event with the Department of Orthopaedics. So we'll move on to the trauma section. The first presenter is Dr. Berk, Alex Berk from University Hospitals of Case Western University, Reserve University. Patients with vitamin D deficiency are more likely to develop complex regional pain syndrome after extremity fractures, a large database propensity matched core study. Dr. Berk?
Alrighty, good morning, everyone. My name is Alex Berk, current PGY1 resident at University Hospitals in Cleveland, Ohio. Thanks to the OREF for having us here today. Today we'll be talking about our recent study looking at the incidence of CRPS in patients with vitamin D deficiency with extremity fractures. No relevant disclosures. To provide a bit of background, complex regional pain syndrome, or CRPS, is a debilitating condition that can occur following extremity trauma. Patients present with a variety of symptoms ranging from hyperesthesia and allodynia to temperature asymmetry, skin atrophic changes or autonomic symptoms, and motor dysfunction. Although the estimates regarding the incidence of CRPS following extremity fractures have been reported to range from less than 1% all the way up to 50%, when considering population-based studies, more specifically, the incidence of CRPS has been consistently reported to be less than 1%. Currently known risk factors for CRPS, including Caucasian race, female gender, mood disturbance, and comorbid inflammatory arthropathies, are largely non-modifiable. And despite multiple theories ranging from autonomic dysfunction to neuroinflammation, our understanding of modifiable risk factors for the pathophysiology of CRPS following extremity fractures remains extremely limited. One potential emerging risk factor of interest in the development of CRPS is vitamin D deficiency. Specifically, vitamin D is known to have anti-inflammatory and neuroprotective properties achieved via the downregulation of the cellular response to TNF-alpha and via modulating serum levels of IL-6 and CRP. Ultimately, it's thought that these immunomodulatory effects may play a role in the development of CRPS amongst patients with vitamin D deficiency following extremity fractures. With this in mind, the purpose of the study was twofold. The first was to determine the role of vitamin D as a risk factor for the development of CRPS amongst patients with upper and lower extremity fractures, and two, investigate the role of surgical intervention in the development of CRPS amongst patients with vitamin D deficiency. To achieve this, we used a retrospective cohort study design using the Trinetics US Collaborative Network database. Inclusion criteria were adults with isolated upper and lower extremity fractures between 2003 and 2022 with minimum 2-year follow-up. We excluded patients with concurrent fractures, polytrauma patients, or patients with a prior history of CRPS. Vitamin D deficiency was defined by either an ICD-10 diagnosis or a vitamin D level less than 20 nanograms per milliliter. 2 cohorts were then generated based on the presence or absence of vitamin D deficiency, and then 1-to-1 propensity score matched based on age, sex, race, and ethnicity. Once the 2 cohorts were identified, the incidence of CRPS was determined and compared between cohorts. Moving on to the results, so there's over 101 million patients included on the Trinetics database in whole. After querying the database, there were approximately 2.9 million that sustained upper and lower extremity fractures that met our inclusion criteria. Of these, 5% of this cohort had a documented vitamin D deficiency as stated in the inclusion criteria. After 1-to-1 propensity score matching, we had balanced cohorts, including more than 150,000 patients each. Baseline characteristics, including age, sex, race, and ethnicity, were well matched with no significant differences between cohorts. Overall, irrespective of vitamin D deficiency, the incidence of CRPS was relatively low, 0.24% in the upper extremity cohort, 0.27% in the lower extremity cohort, sort of consistent with these other population-based studies. When looking at the role of vitamin D, we found that patients with vitamin D deficiency had a significantly higher incidence of CRPS after both upper and lower extremity fractures. The odds ratio for the upper extremity was 1.6 and 1.78 for the lower extremity. Lastly, we looked at a subset of patients who underwent operative fixation of extremity fractures. Interestingly, this subgroup of vitamin D deficiency was not significantly associated with increased CRPS risk, potentially due to the relatively smaller sample size and just the overriding influence of the surgical trauma itself. To conclude, we found that consistent with the existing literature, thankfully the overall incidence of CRPS following extremity fracture remains relatively low. Additionally, we found that vitamin D deficiency is independently associated with an increased risk of CRPS after both upper and lower extremity fractures, and that amongst these patients with vitamin D deficiency, surgical intervention does not further increase this risk. And while these findings certainly don't imply causation, with over 1 billion people around the world affected by vitamin D deficiency, it offers a new lens through which we might better understand CRPS, potentially enhancing strategies for its prevention and treatment. Thanks.
Thank you, fantastic. The next presenter is also from Case Western, Dr. Lucas Blumenschein, outcomes of a curved interosseous fixation device for pelvic fractures.
Somehow we gave Case Western the entire trauma section. So, I'll have to talk to Lutz about that. I'm not sure if you paid us off for that or what. A lot of trauma in Cleveland.
There is, yeah.
Not only the Browns.
A lot of emotional trauma there, mostly. All right, hello. I'm Lucas Blumenschein. I'm on PGY3 at Case Western. Thanks everyone who's hosting. Thanks to my PI, Dr. Wetzel, and my co-author, Keira Smith, who will be handling all the questions at the end of my presentation. Disclosures, brief outline. So as a very brief background, pelvic ring and acetabulum fractures encompass a wide variety of injury patterns. They're associated with concomitant injury, they're costly, and these patients have a decreased quality of life and autonomy. And just generally speaking, they're some of the most serious injuries we manage. Management continues to evolve and varies from non-operative management to open versus percutaneous fixation. Historically, operative management consisted of open fixation methods, though since its introduction in 1993, percutaneous fixation has demonstrated itself to be a safe and effective mode of treatment that minimizes blood loss, complications, pain, hospital stay, and infection that is associated with open management. Percutaneous fixation does pose challenges in the pelvis, specifically the three-dimensional complex anatomy of the pelvis with curved corridors, treating with traditionally straight implants. So the purpose of this study was to evaluate the use of a CurvaFix implant, a curved intramedullary implant, in patients with unstable pelvic ring and acetabulum fractures. This was a retrospective cohort study looking at patients fixed with this implant at a single level 1 academic center done by 3 surgeons. Just as a very brief overview, this is kind of a picture of the implant. It's an intramedullary implant for the pelvis. It's flexible on insertion and when placing it, and then it can be locked rigid once it's in its final destination. So our cohort was small. It only consisted of 27 patients with a wide spectrum of pelvic and acetabular fractures. The average follow-up was 5 months. Average time to weight bearing was 29 days, and time to radiographic union was 113 days. There was no correlation between any medical comorbidities and time to weight bearing or radiographic union. And kind of the most interesting thing, at least to me, is there was no recorded complications or reoperations in this cohort. And then much more interesting than anything I have to say, I have a couple pictures of some of these injuries. So here we have a 76-year-old male with a right LC2, right anterior column and left anterior ring. And just an example of what this implant kind of looks like and how it's able to conform. Here we have a 70-year-old male with a left LC1 injury pattern. And here with the implant on the left side, showing how you can kind of bypass the pubic symphysis, something you can't really do with traditional straight intramedullary implants. Here we have a 74-year-old female with a right LC2, and just showing that you can place this in the wing and the LC2 corridor, and again in that right anterior ring portion. Here we have a 95-year-old female with a right LC1 and a minimally displaced posterior column fracture with an anterograde posterior column fixation. And then lastly, a 76-year-old female who was having chronic pelvic instability, used transsacral transiliac. So some limitations in a summary. We're working on a larger cohort. We're working on a comparative wing as well as a prospective wing. But at least based on this study we have now, we think this implant is safe and allows for early weight bearing and radiographic union within a reasonable time frame. Thank you very much.
Interesting, thank you. Next, continuing with the tradition here, from Case Western, Dr. Margaret Sinkler, to fix or to replace an analysis of geriatric periprosthetic distal femur fractures treated with open reduction internal fixation, retrograde intramedullary narrow, or distal femoral replacement.
All right, good morning. My name is Maggie Sinkler. I'm a third-year resident at Case Western, keeping with the theme. Thanks for the opportunity to give a talk today. Today we're going to talk about to fix or to replace an analysis of the treatment of geriatric periprosthetic distal femur fractures. All of our disclosures are available on the Academy website. So when we look at these periprosthetic distal femur fractures, these are particularly debilitating injuries. They have a significant morbidity and mortality. A lot of this is due to the prolonged immobilization after these injuries, high non-union rates, and the physiologic burden. So when we look at what are our treatment options for these injuries, the historic standard of care is using open reduction internal fixation. Some of the proponents of this method say that it preserves bone stock in addition to having fallback salvage options if needed. But this is also associated with a delayed weight-bearing period following this strategy. So then on the other side, people have started using distal femoral replacement to address these injuries. Historically, this has been reserved for patients with loose components, insufficient bone stock for distal fixation, but it has a big benefit of allowing patients to immediately weight bear. Although this is a maximally invasive strategy, and it typically is seen as a salvage option for most providers. But then what about retrograde intramedullary nailing? So with the modern knee implants that we're using that have an open box format, this has become a really favorable option in the eyes of most traumatologists. So this technique has minimal soft tissue dissection, and minimal perosteal stripping, so therefore it has decreased postoperative stiffness, but it sometimes can be limited due to the knee implant with the box size. So what we looked at in this study is we're going to compare the outcomes of all these techniques. We're going to look at OREF, retrograde nailing, and distal femoral replacement in a multi-center study within one metropolitan area. We're going to look at length of stay, readmission, reoperation, and then 1 year mortality. So this was a retrospective review done between 2015 and 2020 across 3 major academic medical centers, University Hospitals, Metro Health, and Cleveland Clinic. They were all type 33 fractures. So all of our patients are over the age of 65. They all had isolated periprosthetic distal femur fractures. We excluded all polytraumatized patients. We excluded patients that had fractures during their primary arthroplasty. We did not include any hybrid fixation methods and anyone with incomplete documentation. We had baseline demographic data collection, injury, and then treatment, and then we also looked at their prolonged recovery course. There were 7 orthopedic surgeons that data were pooled in to create this study. So 5 of them were traumatologists, 2 of them were arthroplasty surgeons. All of the DFRs were performed by the arthroplasty surgeons, and then all OREFs were done using a lateral locking plate. So we got approach dictated weight bearing within this study. So all of the DFR patients were immediately weight bearing as tolerated. The OREF group was non-weight bearing for a period of 8 to 12 weeks. And then our nailing cohort was either weight bearing as tolerated or partial weight bearing. So across the centers, there were 377 periprosthetic distal femur fractures. We did have a lot of patients that we had to exclude due to the exclusion criteria that we mentioned earlier, but our final cohort is 163 patients. Looking at the basic demographics, we found no differences across the cohorts. And now we'll get into our main outcome. So this is not surprising. So looking at time to weight bearing, the OREF cohort has a significantly higher time to weight bearing at 88 days. Looking at length of hospital stay, we see that our distal femoral replacement cohort stayed on average about 3 days longer than the other 2 cohorts. And this also came out when we looked at this in a multivariate analysis. It remained a significant risk factor. When looking at reoperation rates, we see that the retrograde nailing group was trending towards being higher, but did not end up being significant, which was also confirmed in our multivariate analysis, which just showed that age was a risk factor for reoperation. Looking at readmission rates, we found that the distal femoral replacement group had a significantly higher rate of hospital readmission that was considerably higher than both the other cohorts, which was also seen as significant in our multivariate analysis in addition to the presence of diabetes. Looking at 1 year mortality, we found higher rates in both the nailing group and the replacement group, which remained consistent for the nailing group and based on age in our multivariate analysis. And then we saw a high rate of the need for intraoperative blood products in both the nailing group and the replacement group. So what all does this mean? So I think that we're at a point now where I think that each approach has their pluses and minuses. What our data shows is the OREF cohort has a shorter length of hospital stay, but it does have delayed weight bearing, although that may not portray to increase 1 year mortality. Our nailing group had a shorter hospital stay, but had more blood transfusions, and increased 1 year mortality, but then also lower readmission rates. Our replacement group had a longer hospital stay, more blood transfusions, and also an increased 1 year mortality. So I think we still have, there are further study that needs to be done, and we need to look at functional outcomes of these patients. We need to look at the cost of care related to these conditions, but I think our institution's opinion at this point is to reserve replacement as a salvage option for these patients. Thank you.
Great, thank you. Can we have all the presenters up on the firing squad here? I can start out with a question. Question for Dr. Berk. So you presented that the vitamin D was a risk factor for CPRS. Do you think that from the clinical application standpoint, do you think then identifying these patients and giving them at the time of injury vitamin D supplements is helpful? What's your thoughts?
I think it's hard to know at this point. I mean, we looked at, upper and lower extremity fractures in sort of 2 separate cohorts as a whole, and so I think to better sort of elucidate the clinical implications of this, we'd have to look in more detail at, specific fracture patterns. I think the most robust data sort of related to CRPS after fractures and distal radius fractures. And sort of as we know, vitamin C is sort of widely recommended, after those distal radius fractures. And so I think that if we're going to translate this study or this data into, being clinically applicable, I think we would have to narrow in on specific, fracture patterns and fracture types, better control for some of these other confounding factors that we weren't able to on this sort of database platform. But I think it's certainly, a possibility.
So while I have you up there, follow-on question. Why not just give everybody vitamin D? It's cheap, it's easy to do.
Yeah.
And I was a little surprised by your data. You showed a 5% vitamin D deficiency in that cohort that you looked at. That sounds really low for me because I think the majority of our trauma patients are significantly higher than that. So how do you explain that?
Yeah, I mean, so I think the relatively, it's probably a limitation of the database itself. Querying the database relies on either ICD-10 diagnoses or, an actual laboratory value for, vitamin D itself. And so again, the incidence of vitamin D deficiency is probably higher than what was, provided or, demonstrated in this study. I think there's plenty of us here living in the Midwest that are vitamin D deficient and probably don't have a documented history of vitamin D deficiency within our medical charts. And so this database, queries essentially from Epic. And so in order to identify these patients, they have to have a formal diagnosis in their chart. And so I think it's certainly something to be mindful of, as we interpret the data, certainly.
This question is for Dr. Sinkler here. I know this is a difficult population, and I know you kind of did the best to try to make sure that they were all sort of equal populations, but do you think some of your data may reflect a little bit of selection bias about sort of who gets treatment for these, who gets the particular surgeries for a particular injury pattern?
Yeah, so probably the best way to phrase this is there's an institutional bias. So, which is why it's a multi-center study in the same metropolitan area. We think that ideally it's a similar patient cohort because it's all people from Cleveland. They're all over, They're all over the age of 65. And we looked at like the generic like trauma factor, risk factors, and we took those into account in our cohorts. But honestly, the reason why we have these cohorts is from institutional bias. So it kind of depends on what trauma center you show up to is what you're going to be managed with.
Can I make I have a question on that too. So I was going to ask you, you talked about time to surgery. I was also going to ask about the length of surgery, but you answered that in the institutional question or statement, because just knowing Cleveland, having rotated a case as a med student, it depends on if you show up where the joint surgeon is. I'm not assuming that you're going to get a distal femur replacement. It's quick. I've got the skill set and I'm popping in more metal, right? You show up in Metro, they're going to try to piece everything back together. You show up at another place, nail.
Yeah.
So with that, what's the next conversation that's happening right now based on this data?
Yeah, so I think the big things are, we're seeing pluses and minuses. I think most people are pushing to have a DFR be a salvage option because most people are saying, okay, we know that if an OREF goes to non-union, that we can always have a DFR in our back pocket. So I think that the push is to make that the thought process of most people. The other big things that I think will help push us to that final end game is looking at the cost of these, which, we're seeing this with the more days in the hospital, cost of implants, I think will help tease out the answer to that question in addition to looking at the real functional outcomes. I think those are the two pieces that are missing that are probably going to kick us over one way or the other.
Can I ask you to one of your data points? So you showed that the full knee replacement option has the longest time of stay. Do you think that's a little bit an a priori finding? In other words, basically, are these patients set up to just stay a few days longer than the trauma patients? Did you look into that?
Honestly, we did not, and I think that's a very good point. Just knowing like our PT protocols and how we handle our joint arthroplasty population, I think it's a good point, but no, we have not do it.
Yeah, and then another point I wanted to make, because that affects us even in sports medicine, is taking somebody off their feet, anybody above the age of 30 for up to 3 months. There's so many other things that go downhill.
Yep.
So that's something that I would kind of really carefully look into, and into secondary unintended costs, that will happen with these patients. They may survive, but what does that do to their overall mobility, quality of life, et cetera? That's really important.
Yeah, and I think we now trend putting all of our retrograde nails immediately weight bearer. So we're looking at updating some of our data to have the retrograde nail group be all immediately weight bearing and see if that helps us. Anything out?
Dr. Blumenthal.
Oh, so go
Go
ahead.
ahead.
No, I've got to ask a question to, I was going to ask Dr. Blumenstein about his, so I love this with the, kind of doc-ock, extension arm of this flexible implant. Is it FDA approved for use? Are you guys a trial site? That's one question. And then the other question is, the time, what about the time and just skill set difference in placing that implant? Are you guys seeing any differences there?
As far as I'm aware, yes, it is FDA approved. It's not that one picture I showed where you're crossing the pubic symphysis. It's not technically, from my understanding, it's used off-label anytime you're going across a joint. With that said, I think that's one of the things that's probably more useful for it, especially in those like pubic symphyseal fractures. You can kind of cross over from poor bone into good bone, so I think that's somewhere that's good for it. As far as, I'd say generally speaking, it seems to me to be easier. These are cases that we as residents don't really get to use, but I've definitely caught a lot of radiation watching the fellow use it. And, especially in these more so like these anterior column and anterior ring starting points and everything. You normally have a very narrow window of where you can actually start and where you can end, and that varies a lot with patient anatomy. So I think this, just being able to kind of find where it wants to go, should make it easier on average.
Just a follow-up question for Dr. Blumenstein. So it's an interesting device. Maybe I missed it, but I didn't see a conflict of interest slide in your talk. Just a comment, was there?
Yeah, Dr. Wetzel is.
Got it, okay, perfect, yeah. So just as a comment that, we all have to kind of, since this is a resident forum, that we have to be aware of that as we analyze your data. And it would be a good thing for us to kind of be able to look at your data with that in light, yeah.
All right, I have a question for Dr. Berk. Yeah, I think it's a very, very interesting study, basically showing that, vitamin D is associated, right? Associated with the CRPS, right? Now, is there any biological reason why vitamin D actually can, let's say, decrease the CRPS?
The pathophysiology of CRPS, I think, is very complex and multifactorial, but
Yeah.
I think there's a lot of emerging evidence and data sort of just related to the inflammatory nature
Yeah.
of CRPS and sort
Yeah.
of the TNF alpha, like I alluded to, IL-6, CRP, all these sort of pro-inflammatory cytokines
Yeah.
that we think about certainly are implicated in CRPS, and then so concurrent with that, vitamin D has been shown and demonstrated in a lot of studies to have like anti-inflammatory effects, and so I think the direct correlation, is still, yet to be known, but I think, knowing the pathophysiology of CRPS in combination with some of these anti-inflammatory properties of vitamin D, that's sort of where that connection comes from.
Yeah, my second question is had to do with the strength of the association. Now, I might have missed it, you presented maybe.
Sure.
How much you were talking about the strength of association? Is 90% can be explained, the association can be explained by the vitamin D, or only, let's say, 5%?
I guess that's a good question. I can't give you an exact number. Again, we did like the propensity score matching to sort of try to control for some of these confounding factors, but I think I would certainly have to go back and look at the data to better sort of give you an answer to that. I think there's certainly other variables and other risk factors that we should and can control for that would sort of help better elucidate, the strength of this relationship. But as far as the actual percentage, I'd have to sort of.
But it's larger, taking 1 million, or more than 1 million, right? Yeah,
the total database, yeah, it's a large database.
Yeah. So, yeah, that's great, yeah.
Thank you.
Okay.
Mac? So that was an outstanding first section, and then as we get ready to go to break, and a round of applause for you guys. great job with that section. One thing I would mention, and Dr. Latterman actually alluded to this when he made the question about vitamin D, and it's just something for the residents to think about. And it ties into why we continue to have these research conversations, the importance of OREF, the importance of BMRC. We are very reactive in medicine, right? We are essentially waiting for something to happen to someone in many cases. We talk about prevention more now, but when you think about vitamin D, vitamin C, all of these things that we know have an impact on fracture healing, why don't we just give them a banana pack like you get, for DTs, right? Someone comes in with DTs with a known history of alcoholism, and if they report that and they are getting admitted, they automatically are triggered to receive all of these vitamins that we know should help prevent them from going into DTs. Is it because we don't want them to be drunk in the hospital? Anybody know? Anybody know why the banana pack was invented? Anyone? No, it's not because we don't want them to be drunk and actually jumping on nurses. Most importantly, we don't want them to have a cardiac event, which we know is associated with the fact if they go into DTs, they will have a cardiac event and it increases mortality. Again, reactive, right? So these are the type of things that I know with a lot of the work of our BMRC and the research you're showing. Maybe Dr. Latterman's right. You show up with certain fractures, maybe you should just get a multivitamin, automatic, triggered. You don't need the resident to forget to order it, or a nurse to forget to give it, or an attending to say, why did you actually order that lab? Have the data push you to just do it. So that was a great job for the morning. And what time do you want to start back, Dr. Lynn?
You know what? Why don't we? We're not too far off, but let's take like a 5 minute.
Yeah, 5 minutes, and then we'll back in the saddle. Great job.
Yes. All right, so we already have 2 sessions this morning. So now we are continuing on the session 3, arthroplasty outcomes. Okay, now my name is James Wan, professor and vice chair of research for Department of Orthopedic Surgery at the University of Pittsburgh here. I would confess, I'm very impressed with your presentation this morning, okay? I expect you have continue perform well in your presentation, okay? With that, let's introduce the first speaker by, I think, Dr. Whitney Kagabo from the Johns Hopkins University. And her talk is the GLP-1 receptor agonist mediated weight loss, improve outcomes after the knee arthroplasty. Dr. Kagabo.
Good morning, everybody. Thank you very much for having me. I am Dr. Whitney Kagabo, PGY4 at Johns Hopkins University. Thank you to Dr. Hegde, my mentor on this project. My paper is entitled GLP-1 Receptor Agonist Mediated Weight Loss Improves Outcomes After Total Knee Arthroplasty. Primary total knee arthroplasty is one of the most commonly performed orthopedic surgeries in the United States, and demand is only projected to increase in the upcoming years. With this increase in volume comes the increase for potential patients with postoperative complications. Therefore, it is paramount to increase patient optimization in a way that decreases complications. Multiple studies have demonstrated that morbidly obese patients undergoing total knee arthroplasty are at increased risk of complications, including increased risk of DVT, PE, and infections. Complications following total knee arthroplasty can significantly impact patients' quality of life and overall satisfaction with their procedure. Revision total knees have a higher failure rate, including higher rates of infection, instability, and loosening. Obesity is a modifiable risk factor that should be optimized prior to surgery to improve outcomes. While preoperative weight loss is often encouraged to reduce surgical risks, there is concern that stringent weight loss goals may delay or even prevent patients from undergoing surgery. GLP-1 receptor agonists are synthetic analogs that act via the incretin pathway and targets GLP-1 receptors. This leads to increased satiety, delayed gastric emptying, increased insulin release, ultimately promoting weight loss in these patients. While initially approved by the FDA for the treatment of type 2 diabetes, these medications have gained popularity for its efficacy in achieving significant weight loss in diabetic and non-diabetic patients. The primary aim of the study was to compare one-year complication rates between patients undergoing primary total knee arthroplasty with preoperative GLP-1 analog-mediated weight loss. Patients went from a BMI of greater than 43 to less than 43, compared to two control groups, patients with BMI greater than 43 who did not undergo preoperative weight loss, and to patients with initial BMI of less than 40 preoperatively. Both control groups did not have prescriptions for GLP-1 receptor agonists. We conducted a retrospective review using the TriNet-X database and queried for patients aged 18 to 100 years old who underwent primary total knee arthroplasty between May 2005 and August 2024. The study period was chosen as GLP-1 analogs first received clinical approval in April 2005. 3 comparison groups were then identified based on patients' BMI and GLP-1 analog-mediated weight loss. Group 1 were patients receiving GLP-1 analogs within 2 years of their total knee arthroplasty with a reported significant decrease in their BMI, from BMI greater than 43 to BMI less than 40 post-op. Group 2 were patients with BMI greater than 43 who did not have a GLP-1 analog prescription. And Group 3 were patients with BMI of less than 40 who also did not have a GLP-1 receptor analog prescription. We then performed one-to-one propensity score matching to compare the groups in 2 separate analyses. GLP-1 versus BMI greater than 43 group, which consisted of 934 patients, and GLP-1 versus BMI of less than 40 group, which consisted of 925 patients, to determine any difference in the risks of developing complications. When comparing complication rates between the GLP-1 group and patients with preoperative with a preoperative BMI of greater than 43 who did not lose weight, the patients in the GLP-1 group had a significantly decreased risk of readmission, 1.2 versus 2.6%, significantly decreased risk of revision surgery, 1.1 versus 2.7%, and decreased risk of periprosthetic joint infection, 1.1 versus 3%. When comparing the GLP-1 group to patients with BMI of less than 40, there were no differences in the risk of developing complications. The primary limitations of this study are inherent to its retrospective design. Data is collected from electronic medical records from healthcare organizations participating in the TriNet-X research network. Additionally, reliance on existing medical records means that data accuracy is dependent on the quality and completeness of these records, which can vary between institutions. Future prospective studies are needed to confirm our findings and to further explore the safety and efficacy of GLP-1 RAs in surgical patients, particularly in the context of orthopedic procedures such as total knee arthroplasty. Randomized control trials would be especially valuable in providing high-quality evidence to guide clinical practice. In conclusion, this study demonstrated that significant preoperative weight loss achieved through the use of GLP-1 analogs can effectively reduce the risk of postoperative complications in morbidly obese patients undergoing total knee arthroplasty. Thank you very much.
All right, so let's move on. Next speaker, I think by Dr. Stephen Dabic from University of Maryland. And his talk is Predictors of Promise Pain Interference After Reverse Total Shoulder Arthroplasty.
All right, good morning. My name's Stefan Dabic. I'm one of the residents at Maryland. Thank you to my team of co-researchers at Maryland. This is the presentation on predictors of postoperative pain interference after reverse shoulder arthroplasty. No disclosures from our team. So the incidence of reverse shoulder arthroplasty has increased in recent years, partly due to increase in broadening indications with satisfactory outcomes. Increased emphasis on patient-reported outcomes makes identifying predictors of postoperative pain in these patients valuable. And one tool that can be used to evaluate that is this PROMISE PI score. And this captures how postoperative pain in the shoulder impacts just day-to-day life, so functional activity. And this kind of encapsulates the 2 goals of primary shoulder or of reverse shoulder arthroplasties to improve pain and restore function. So the purpose of this study was to investigate what are the predictors of this pain interference score 2 years after reverse shoulder arthroplasty. So our cohort of patients are patients undergoing reverse shoulder arthroplasty between 2015 and 2022. They are prospectively enrolled into our orthopedic registry. As part of their enrollment, they have several patient-reported outcomes that are collected, including PROMIS scores with various domains. Pain interference is one of them, but we also collect physical function, fatigue, social satisfaction, et cetera. And then other scores, including the ASES shoulder score, numeric pain score, and others. So for our methods, we evaluated this with univariate analysis, but then we also built a statistical model using least squares regression in a backwards stepwise elimination method, meaning we included a bunch of variables that we thought either a priori would be predictive of this pain interference, as well as those that on univariate analysis were significant with a baseline pain interference score. So for our results, we had, again, another impressive 83% completion of 2-year post-patient reported outcomes for this analysis. There were 99 shoulders, 99 patients that were included in this analysis. Worst baseline pain interference was associated with greater BMI, higher Charlson comorbidity index, and preoperative narcotic use. Worst 2-year PROMIS pain interference score was associated with preoperative narcotic use, again, a legal claim, and prior ipsilateral shoulder surgery. As far as the surgical details, so these are the indications that for which we perform reverse shoulder arthroplasty. The majority were for cuff tear arthropathy, followed by glenohumeral osteoarthritis, and then proximal humerus fracture, as well as irreparable rotator cuff. And on this just group level analysis, comparing to irreparable rotator cuff, there's a greater 2-year change in pain interference with rotator cuff arthropathy and osteoarthritis, meaning those patients who underwent reverse shoulder arthroplasty for those indications did better compared to those for irreparable rotator cuff tear. So after creating our model, we found that predictors of pain interference from the shoulder condition worsened with preoperative narcotic use, an irreparable cuff tear, legal claim for the injury, and baseline numeric pain scale of the body. And so, while those were significant at the univariate analysis, we also saw that they were remained significant at the multivariate analysis. So, preoperative narcotic use, legal claim, irreparable rotator cuff tear, and worsened baseline numeric pain scale of the body were predictors of a worse 2-year PROMIS pain interference score. So this is just something, these are good for several aspects of clinical care, just to manage expectations, counseling patients with some of these modifiable, sometimes non-modifiable categorical or situations that the patient has. So just to kind of give them something, a framework to balance expectations on what they can expect following surgery. These are my references, and thank you.
All right, so we have a next talk by Dr. Michael McCurdy, also from the University of Maryland. And he's going to talk about the predictors of a completed better status 2 years after shoulder arthroplasty.
Sorry, I'm having trouble moving the cursor here. Got it. Yep, good. Yeah, I think I got it here. Thank you. All right, good morning. My name is Mike McCurdy. I'm a current research fellow and incoming PGY1 at University of Maryland. I'm presenting predictors of completely better status 2 years after shoulder arthroplasty. My authors and I have no relevant disclosures. Recent focus on clinical interpretation of patient-reported outcomes has led to the development of several metrics that are widely used in the orthopedic literature. MCID, or the minimal clinically important difference,
captures the minimal improvement necessary to note a clinical difference in patients at their postoperative follow-up. SCB, or substantial clinical benefit, captures the improvement necessary to note substantial benefit, and PASS, or patient acceptable symptom state, notes the postoperative PROs, that threshold necessary for a patient to deem their symptoms acceptable after surgery. Though well studied, these metrics may fall short of capturing the ultimate patient-centric goal of feeling completely better postoperatively. So the purpose of this study was to identify associations between patient demographics, PROs, and achieving completely better status after total shoulder arthroplasty. Additionally, we want to identify possible preoperative predictors of achieving completely better status after total shoulder. So total anatomic or reverse total shoulder arthroplasties were enrolled from June 2015 to April 2022. And as my previous presenters had explained, all these patient-reported outcomes were collected in this registry, including PROMIS, the American Shoulder and Elbow Surgeon Score, numeric pain scale, and variety of activity rating scales. For statistical analysis, outside of our typical univariate analysis, we did calculate the minimal clinically important difference using a distribution technique of 1/2 the standard deviation of the baseline distributions of each of these PROs. And patients with 2-year improvement greater than this value were deemed to have achieved the MCID. And we also did a multivariable analysis to identify predictors. Overall, the cohort, 65% answered the completely better anchor question, which asked, is the condition for which you underwent surgery completely better after surgery? About 57% of these patients were male, and the most common indications were glenohumeral osteoarthritis and rotator cuff arthropathy. 95 patients, or 77%, reported being completely better after surgery. At baseline, completely better patients had better PROMIS physical function and higher preoperative expectations of surgery. And at 2 years postoperatively, completely better patients had better PROs in almost every metric, as detailed there by the bold and asterisk values. And when looking at 2-year improvement in these metrics, completely better patients had greater improvement in PROMIS anxiety, depression, ASIS, and MPS of the operative shoulder. When splitting up the completely better and not completely better groups into those who achieved MCID in these respective PROs, completely better patients had a significantly higher percentage of patients achieving the MCID for ASIS and MPS of the operative shoulder. On regression, our multivariable model identified that older age and better baseline PROMIS physical function were the 2 predictors of achieving completely better status after shoulder arthroplasty. In conclusion, demographics and surgical details were largely similar between these patients who achieved completely better and those who did not. When comparing our rate of completely better to other literature that discussed pass rates, we do have a slightly smaller percentage of patients achieving completely better than pass, which may indicate that our more stringent threshold of being completely better after surgery was achieved. Completely better status was associated with better 2-year PROs in various domains, including function, pain, satisfaction, and mental health measures. And when comparing our median or mean values in the completely better group to other reported values in the literature, we pair up favorably well. And again, older age and better baseline PROMIS physical function were predictive of achieving this completely better metric after surgery. So roughly 77% of patients achieved completely better, and older age and better physical function are preoperative predictors of achieving this status. So future prospective studies should be performed to evaluate differences between reverse and anatomic in achieving this completely better status in the future. And these are references. Thank you very much.
All right, so can I ask all the speakers come on the stage? All right, so let me start asking question for you, Whitney, right? Yes. Yeah, I think it's an interesting study, and GLP-1 drug is kind of, relatively speaking, it's a new drug to control the, blood sugar, blood glucose level, right? So I think it's not very surprising if you control the glucose level and you get a weight loss, and you're probably in better shape. Basically you have better health conditions, right? So you get a better outcome, this arthroplasty, right?
Not necessarily, because this wasn't just in patients who had diabetes. So this is also in patients who do not have diabetes, who already at baseline have good blood glucose control. I think that this just further supports the data that patients who are below a certain level of BMI have, likely better nutritional status, better, other factors that decrease their risk of complications. And, at my institution, there's a strict BMI cutoff of 40 for surgery. And it can be very difficult because patients, don't always have the resources and the means to be able to lose the weight. And currently, the other option studies that have been done included bariatric surgery, which declines your nutritional status in certain ways and does not necessarily improve your outcomes. There is, losing weight with exercise and diet, and that can be a very tedious, long, and difficult process. And there's been studies that have demonstrated that over 50% of patients may never undergo surgery because they were never able to lose that weight. So to have a medication that could help them lose the weight and improve their outcomes is something that could be very important for the future.
I'm going to follow that up because it was an EMR study, and over the time period that you studied these patients, the only indication for getting the drug was control of diabetes.
So that's the only FDA approved, but it's been multiple years now that patients, that prescribers have been using it as a means for weight loss. And so not just for diabetes, but also for patients with...
I understand, but I'm telling you just what you could get the drugs paid for. And I used to work at Hopkins, and I know the patient population, so they had to get it paid for.
Yes.
So they were probably diabetics. And so my question is the confounding factor of was the glucose better controlled on the GLP-1s pre-op and perioperative, because keeping the glucose below 200 is a key factor in terms of perioperative complications. And did you look at the control of the glucose? And I just suggest that that's a confounding factor to look at before you publish.
Unfortunately, because of the use of an EMR, we do not have that data, but I think that we are considering doing prospective studies, and we will definitely use that information when we conduct those trials.
Keeping the sugars low.
Yes.
May be more important than the weight.
Yes.
So, and then, as long as I have the mic, I have a question for the first speaker from Cleveland. Or Maryland. You're in Maryland. Now, Cleveland was the trauma people.
Yeah.
All right.
It's an arthroplasty section, so it's your moment.
It's all right.
Yeah.
On the in your study, you have access to PROMIS, and I'm assuming you have the factors that are in PROMIS 10, and it is known that the outcomes in for Who's Jr. and Coos Jr. Actually are very much affected by the mental health domain score in PROMIS 10. Was there any attempt to use that as a risk adjustment, given the fact that it's actually used in the CMS performance measures to capture that as a risk factor for outcomes?
So yeah, I think that's a good question. We didn't use that, to my knowledge, at all. But I think that problem with our study, I think, is we have a lot of variables in our model already, and it's just increasing. We're introducing too many variables. It kind of makes it so that we're almost like overfitting to our particular patient population. But I do agree that that's something that really kind of influences all of those scores. So I think that's something we can go back and take a look at.
Yeah, finding that will be hard because you have to go into the methodology on CMS from Yale Core, but it was definitely found when they ran it against 500,000 patients. And it's why we still have the capture PROMIS 10 when we report Who's Jr. and Coos Jr. For the lower extremity.
Okay.
And one, if you can just humor me, the last question. You were bringing up the totally better score. In lower extremity arthroplasty, we talk about the forgotten knee, and that's considered the home run, and it doesn't happen as often as 75%. But is this is this language, is this analogous to what we would call the forgotten knee? And the second question is, again, we're struggling having to report to Medicare on our patient-reported outcomes in lower extremity, but we're using significant clinically better outcomes, as opposed to just minimal. And that's, again, that's an anchor technique that's based on the correlation that was found at HSS for that. So do you see anything, is this the significant clinical better difference, or is this the forgotten shoulder?
Yeah, it's a good question. I think in reference to your question about the forgotten knee, the way the question is phrased in our REDCap database collection is the condition for which you underwent surgery completely better now. Now, does that necessarily mean that what you're alluding to in the forgotten knee has been achieved? I think it's hard to speculate. Obviously, patient-reported outcomes have a large amount of subjectivity, and we're aiming to capture something that's as high as possible while also understanding that patients have different interpretations of completely better. So I'm not sure we're exactly nailing the forgotten knee level. But I will say that in kind of referencing this with the current literature on PASS, that we're achieving maybe a more stringent threshold for that kind of technique. When it comes to substantial clinical benefit, we actually don't have that in our database collection. So we used the distribution method to calculate MCID as just kind of a corollary to show where we're at and what kind of PROs were associated with achieving completely better. But since we don't have that anchor-based methodology in our database collection currently, we couldn't really make that same comparison with SCB. Yes. Got it. Thank you very much.
This question is for Stefan. As the world heads towards value-based care, I think patient-reported outcomes, ability to collect them, and institutions that are able to collect them are going to be better equipped to deal with things like potential reimbursements tied to that, right? So you got like an 83 or sort of 85% response rate at 2 years. That's actually quite high. So what's your secret sauce here? Because, you know, these are hard to track, especially at 2 years and beyond that.
Yeah, I think we have a really robust infrastructure just at our institution. We have several research fellows and research interns who are kind of involved in collecting that. That's really the methodology that we're able to do that. And also, I think our patient population that goes to the specific surgery center that does the majority of our reverse shoulder arthroplasty, I think that might not be representative of Greater Baltimore necessarily, or even nationally. So I think that there's a lot of bias geographically and demographically in our database for that. Yeah. Yeah.
I have a question for Michael. So you compared your completely better score, and in your introduction you said, you know, PASS, the MCID, etc., they don't really capture the ultimate question, right? And this is why you're looking into this completely better. And when you present your data in the end, there's a very, very high correlation and very high comparability between the score, the PASS score, and the MCID reported in the literature to your completely better score. Your completely better score is one question. For the MCID or the PASS, that requires a whole set of questions in order to answer that. One of the biggest challenges that we have with these follow-up questionnaires is that you have, the more questions you ask, the more you lose people. Right? So are you working on validating the CB score to potentially reduce the overall numbers of questions that may need to be asked? Because that would be a truly kind of game-changing kind of step forward for that. We are looking for this kind of golden bullet in a lot of places.
Yeah, it's a great question. I think you know, when Dr. Henn initially started this database over 10 years ago now, I think the intention was to kind of make these associations, correlations between this completely better question and the current tools that we have to use. I think the hope is that in the future we can absolutely reduce the number of questions in our survey, because currently, as you allude to, we have promise, we have legacy measures, we have numeric pain scale. Completely better is actually at the end of our survey, so oftentimes patients don't get to that question. And more often we're focusing on promise because that was kind of what the database was built out to intend to measure. Hopefully when we're starting a new database in hopefully the next year or two, and we might consider kind of reorganizing some of those questions so that we have a better idea and better fill out rate of this completely better question, and see if that is really something that we can use moving forward.
All right, so we have to move on. Thank you very much. Yeah.
All right, excellent. Quick question, is Dominic here or is, okay, you are, okay, all right, good. So, so the next section will have two speakers here then. This is sort of the hip and knee section. And first speaker here is Leah Henry from University of Maryland. We'll round out the U of M folks here. Postoperative opioid consumption and 2-year outcomes after hip arthroscopy. Thanks, Leah.
Hi, my name is Leah Henry. I'm a PGY4 resident at University of Maryland. The title of my research presentation today is Postoperative Opioid Consumption and 2-Year Outcomes After Hip Arthroscopy. So the authors and I have nothing to disclose. So an introduction, several studies have previously associated preoperative opioid use with worse patient-reported outcomes after orthopedic surgery, including hip arthroscopy. However, few have studied the impact of postoperative opioid filling on patient-reported outcomes 2 years after surgery, and specifically for hip arthroscopy patients. So with that in mind, the purpose of the study was to investigate the impact of discharge and postoperative opioid filling on patient-reported outcomes 2 years after hip arthroscopy. So patients undergoing hip arthroscopy from 2015 to 2022 at a single institution were identified from a prospectively enrolled orthopedic registry. Pros were collected at baseline and 2 years postoperatively, which my co-residents detailed through, so I won't do that again. But specifically for my study, I looked at opioids, so all opioid prescriptions that were identified in the Prescription Drug Monitoring Program, or PDMP, were categorized as preoperative, discharge, or postoperative according to the date that they were filled. All prescriptions were standardized to morphine milligram equivalents, or MMEs. For our statistical analysis, Wilkinson ranked some tests were used to compare non-parametrically distributed variables. Spearman's rank correlation coefficient testing was used to compare continuous variables, and the minimally clinically important difference, or MCID, was calculated as half standard deviation of the baseline distribution of each patient-reported outcome. And when a patient had a 2-year improvement in PROs greater than this value, this was considered achieving MCID, and chi-square tests were used to compare MCID versus non-MCID. For our multivariable analysis, it was conducted by using the least squares regression with backward stepwise elimination to identify PROs with discharge or postoperative MMEs as a predictor. For our results, of the 127 patients who underwent hip arthroscopy in our registry from 2015 to 2022, 88 completed 2-year patient-reported outcomes and were included in this study. Among the demographic characteristics, greater postoperative MMEs were associated with obesity, prior ipsilateral hip surgery, lower income, and preoperative opioid use. Looking at the relationship between postoperative morphine milligram equivalents and patient-reported outcomes, we found that greater postoperative MMEs were correlated with worse baseline PROMIS fatigue, social satisfaction, and MARS activity, worse 2-year PROMIS fatigue, technical activity, and MARS activity, and worse 2-year improvement in technical activity. Patients achieving MCID and PROMIS pain interference at 2 years filled significantly less postoperative MMEs. And then in our multivariate regression analysis, we found that greater postoperative MMEs were an independent predictor of worse 2-year pain score for the operative hip, worse 2-year MODEMS expectations. However, we found better 2-year PROMIS depression. So in conclusion, postoperative opioid consumption was associated with lower income, obesity, prior hip surgery, and preoperative opioid use. Greater postoperative opioid use predicted worse MPS hip and med expectations 2 years postoperatively, and these findings suggest increased postoperative opioid use may negatively impact pain and expectation fulfillment after hip arthroscopy. Thank you.
Excellent. Thanks so much, Leah. Next speaker is Dominic Ventimiglia. Hopefully I pronounced that right. From the University of Maryland, he's going to talk to us about predictors of completely better status 2 years after meniscectomy. Hopefully not the forgotten meniscectomy.
All right, so my name is Dominic Ventimiglia. I'm PGY1 from the University of Maryland. I have the interesting challenge of being the second completely better talk today. So I'll be presenting our study on predictors of completely better status 2 years after meniscectomy, but it might be an interesting opportunity to see how the completely better question plays out in this cohort. We have no disclosures, full disclosures on the Academy website. So there's been a big push to use patient-reported outcomes in clinical research, and so we use that a lot, not just in our group, but in other talks that we've seen today, using patient-reported outcomes to try to capture clinically relevant outcomes for patients. And recently, there's been another push to sort of contextualize those outcomes because the score alone sometimes doesn't give you all the information. And so that's led to the creation of several different metrics, which Mike explained earlier, but we can think of those ranging on a spectrum from some level of the minimal amount of change that a patient may perceive up to an acceptable level of change. And then we've used this metric of completely better and placed it kind of on one end, the furthest end of the spectrum, where we kind of see it as the ultimate goal is for a patient to undergo surgery and feel completely better after the surgery that they underwent. So the purpose of this study was to look at this completely better metric in our meniscectomy cohort. So we looked at patients undergoing arthroscopic partial meniscectomy and trying to correlate or identify the associations between different patient factors and feeling completely better after this procedure. And then seeing if we can identify any preoperative predictors of achieving this completely better status after meniscectomy. So again, this was a single center study using our institution's registry data. We looked at all of our patients who underwent arthroscopic partial meniscectomy from 2015 to 2018. We excluded patients who had concomitant ligament reconstructions, meniscus repair surgery, or concomitant cartilage procedures. So for the most part, this was just isolated partial meniscectomy. And then again, our registry collects a wide range of patient-reported outcomes, which you can see here. And so this is our completely better question, just spelled out for you all. So we just asked, is the condition for which you underwent surgery completely better now? And there's only two answer options, yes or no. And again, the beauty of this question is in its simplicity, and also the fact that it's not, as we've seen, it correlates with patient-reported outcomes which are currently in use, but it's not necessarily tied to anyone's specific domain. So patients may, undergo surgery with different goals or particular outcomes in mind, and so this metric allows, some flexibility for the patient to interpret the question based on what their specific goals were for the procedure. Be it pain or function or return to activities and things like that. So in order to identify associations with achieving completely better status, we did a univariate analysis using Wilcoxon rank sum test or Pearson's chi-square test, and then again we did a multivariable analysis using least squares regression to try to identify preoperative predictors of achieving completely better status. You can see the variables here on the screen to the right. So we selected a number of variables which we believed would be associated with outcomes after meniscectomy surgery. And then we also identified one other variable in our univariate analysis, which was contralateral compartment cartilage damage. So in this cohort, we had 177 patients. 64% answered the completely better question. And of those patients, 57% reported being completely better. There were some associations with some baseline patient characteristics in those who achieved completely better status versus those who didn't. And those factors were lower BMI, being employed, having higher alcohol consumption, having had no prior knee surgery, and not having any cartilage damage in the contralateral compartment for which they received the meniscectomy. So these are our results. And not shown here, but at baseline, there was no difference between the completely better groups and the not completely better groups in terms of their patient-reported outcomes. But you can see at 2 years, the completely better group had reported better patient-reported outcomes across all measures. And when we look at the amount of change that they experienced from baseline to 2 years, again, the completely better group reports a significantly greater change from their baseline level in almost all metrics, except for a couple of metrics, including the pain score for the full body and for the MARS score, which is one of our activity scores. And then looking at the results of the regression, we found that BMI was a significant predictor of achieving completely better status after meniscectomy. So those with lower BMI were more likely to achieve completely better status. And then additionally, we found that having cartilage damage in the contralateral compartment for which they received the meniscectomy procedure, or not having cartilage damage in that compartment, was a significant predictor of reporting completely better status after surgery. So in conclusion, in this cohort, we had 57% of patients achieve this completely better status. Completely better status, again, was associated with better 2-year absolute values in PROs, and also the overall change from baseline to 2 years. And then we found that obesity and having cartilage damage in the contralateral compartment at the time of surgery were independent predictors of achieving completely better status. Thanks.
Excellent. So we'll have the two come up here for some questions. So we're going to call a little bit of an audible. So after this Q&A session, we're going to continue to go through with the last section for the miscellaneous category. So I can start off with the questions here. So Leah, nice study here. There's a lot of studies in orthopedics looking at opioid use, both sort of pre and post, and that affecting having poor outcomes. My general feeling when I look at a study like this is that it probably reflects something else other than opioid use. And how to arrive at figuring out that something else is a little bit, I think, can be a little bit challenging. So what are your thoughts about sort of how to design a study potentially to look at those factors? Because presumably we want to get to the point where we can have modifiable factors if they affect, outcomes so significantly.
Yeah, it's definitely something I thought about in this study. And just anecdotally from providing care, just seeing patients that tend to use more postoperative opioids, they just tend to have other factors and just be like, oh, it's that certain type of patient. It's hard to pinpoint exactly what that is. I think we did the best we could. We do have a lot of demographic factors in our study. We did control for that. So we did the best we could, but I think that's an area for future study that we need to pinpoint exactly what that is, and we don't know right now.
So the question that I have here is when you were looking at the data, you looked at your patient between 2015 and 2022, I believe. In my practice, in my 2 different places that I practiced in that time frame, there was a significant change in how opioids postoperatively were used. Did you account for that in your study?
We did not account for that, but that is an area we actually want to do a study of that, because we did have a significant change. And it's actually been over the course. I was a student at Maryland as well, so I remember, specifically the sports providers who were prescribing significantly more opioids. That is a study that I want to do, something that we didn't account for in this study, but I want to look at that.
Yeah, I have a question about the completed better. Okay, I got a little bit confused. It's about the probably semantics. You ask a patient, say, are you completed better? So basically, you're asking him or her, you are healed without any issue, without any lingering issues, right?
Correct.
Now, for your case, it's meniscus, right? Removal or repair or something, right? But if I feel if in patient's mind, if his baseline is, well, so painful, so I come to the surgeon, I want to do the surgery. And then after surgery, I feel better. But I only have two choices. I think, it's yes or no, right? So I say, oh, yes. Basically, it means I feel better, but it's not completely better. Am I mistaken? Or?
Yeah, I mean, essentially, so the question leaves open to some interpretation for the patient. But I think that's a limitation of all patient-reported outcomes. They're open to some interpretation for that patient. And so, we're a little bit early to really be able to use this metric as our sole metric for patients. So that's why we're still kind of in this transition area where we're capturing both the traditional patient-reported outcomes and the completely better metric to further explore, how this correlates and what that metric actually means. But yes, it is open to interpretation. But we believe that's a limitation of all patient-reported outcomes.
So for the follow-up question for that, so when you ask a question, are there follow-up questions to, are you completely better? If not, why not, or how much better?
There is, but we haven't analyzed that. We like the simplicity of the yes or no. But yes, if the patient answers that they're not completely better, then there is sort of a Likert scale that's prompted where they can further delineate how much improvement that they've had. But we feel that that's a slightly different metric than the completely better metric on its own, because that sort of Likert scale starts to get more closer, down on the spectrum, closer to more of a pass type of metric.
Yeah, the reason I'm asking is kind of an interesting concept. Again, I'm a spine surgeon. I never ask my patients, are you completely better? Because the answer is always no. Well, not always, but maybe. Foot and ankle probably the same, I don't know. Yeah. And I suspect shoulder is probably the same too. But I always ask though, are you better off than before surgery?
Yeah.
Which to me is a little bit of a better question. And a lot of those patients say yes. And then the follow-up question is, did I make you better, or would you do this again? Not would you do this again, but but no one will ever have another surgery. But if you were given another chance to get to where you are, would you take that chance again?
Yeah. Yeah, no, that's a good point. And we actually asked that exact question in our study as well, just haven't analyzed it as much as completely better. And it's a fair point. When we initially started looking at this metric, we wanted to look at it in cohorts where it was more reasonable to expect to be completely better. So the first cohort that we actually looked at and we published on this was in our patients undergoing ACL reconstructions. Because we felt like for that population, they have an injury, and for the most part, they're younger athletes that we're seeing at our institution. And so for those patients, they reasonably expect they have the injury, they get the surgery, and then they go back to playing the same level of sports that they did before. At least that's the goal that we, hope to be able to provide for them. So we initially looked at it in that cohort. And we just found it very interesting. So now we've kind of tried to expand it to some other cohorts where it may be a little bit more debatable whether it's possible to achieve that level of improvement.
So you're getting to the actual crux of the problem, right? So you have completely better in 57% of your meniscectomies. Well, that's a coin toss, right? Right. So what are you telling your patients? You have a chance of getting better 50% of the time, right? And that's the problem with that question, right? Because if you look at the past scores, they're significantly higher for that patient population, right? And if you have an interesting metric in there, you look at the IKDC, and in the patients that got completely better, the IKDC was at 75. Whereas the ones that didn't, it was at 57. So that indicates that there's some functional issues that play a role here that may actually not have anything to do with that meniscectomy that you did or not. And this is where the problem is, right? Because the next thing that happens is an insurance carrier will go and say, hey, listen, you know, your patients, 50% of them get better, 50% don't. And then that's where the arguments come in, where they say, well, you know, everybody should just be treated non-operatively to the wazoo until they can't walk at all. And then the answer will be, yes, I will be completely better if you beat it into them. Right? And this is a little bit the crux with that. So what is really, really important is that your starting slide, where you basically show, whenever you talk about this, there is a spectrum and there's different answers that any of these scores will give you. But completely better is not a metric that you could utilize in surgeries that live on a spectrum. All right, so keep that in mind. This is really important because that can be, you know, very, very common term these days that can be weaponized, and that has already happened.
Yeah, I think that's a great point. And yeah, one thing we want to do with our update to our institution's registry is to actually incorporate the substantially clinically better question so that we can kind of correlate that with the completely better question. But we don't currently have that SCB question built into our registry.
Excellent. Thank you very much, Leah and Dominic. Great presentations. Yes.
Okay, so we'll continue on. The next section is miscellaneous, which means one of the fantastic sections of all time. That's what that means. So next presenter is from Long Island, Dr. DeGovia, quantification of doxycycline and vancomycin elution from 1.5 millimeters and 2.0 millimeter commercial high-strength sutures.
Did you fly here from New York or did you drive?
I flew.
Yeah, great. Did anybody else fly here? Everybody else? Oh, great. Yeah, great. Excellent. Just curious.
That's it. Perfect.
You guys didn't do a collective, minivan from New York. Oh, I have to talk to those guys. They got to treat you better.
Yeah, I'm on call tonight, so got to fly back. Hi, I'm William. I'm a PGY3 from the North Shore Long Island Jewish Health System out of Long Island. And today I'll be presenting on the quantification of doxycycline and vancomycin elution from 1.5 and 2 millimeter commercial high-strength sutures. I don't know where the slides went. Okay, here we go. So depending on what statistics you look at, as a bit of background, anywhere from 13 to 33% of sutures used in arthroscopic rotator cuff repair are subject to intraoperative contamination. Ultimately, what that risk factor yields is an increased chance of re-tear and possible subsequent intervention. So the sutures widely used for arthroscopic rotator cuff repair are usually braided or tape-like in design. The multifilament structure creates more surface area, but also creates microscopic cavities, which you can kind of see on these electron micrographs, and that increases the retention of debris, bacteria, and fluid, and therefore increases the chance of contamination. So it poses itself to a clinical question of how can we mitigate that risk intraoperatively. So the purpose of the study was therefore twofold. One was to determine the feasibility of the high-strength sutures with either doxycycline or vancomycin that can elute over time, and two would be to quantify that elution profile over several time points in 2 different sized sutures. So the methods for this study, it was very much a basic science study. We utilized 4 types of sutures. We utilized 1.5 millimeter active braid and 2 millimeter active braid, and then our size controls were 1.5 millimeter labral tape and 2 millimeter fiber wire. Each suture was then coated in various antibiotic solutions. We utilized 4, and the solutions were comprised of 8 milliliters of 10% porcine gelatin and then 4 milliliters of an antibiotic solution. In our doxycycline cohort, we took 100 and 200 milligrams of doxycycline, diluted it in 6 milliliters of 10 millimolar hydrochloric acid, yielding a final concentration of 5.56 and 11.1 milligrams per milliliter respectively. And in the vancomycin cohort, we had 80 and 160 milligrams of vancomycin diluted also in 6 milliliters of 10 millimolar hydrochloric acid, giving us a final concentration of 4.4 and 8.9 milligrams per milliliter respectively. We then took 40 centimeters of each suture type, dip coated them in each antibiotic solution, removed them, and then dried them for 4 to 6 hours at 25 degrees Celsius, stored them overnight at 4 degrees Celsius, and then after that they were partitioned into 1 centimeter pieces, each of which was then allocated into a well similar to the one in the top right, covered with 1.5 milliliters of phosphate buffered saline, and then over 7 days we measured aliquots from that saline, and then each day after the aliquot was taken, the suture was placed back into a new well with new saline added. And then we used an ELISA technique to quantify the antibiotic elution. So in the results in the doxycycline cohort, on the left you can see a graph demonstrating the elution in the 1.5 millimeter sutures, and on the right the 2 millimeter sutures, and you can see consistent elution over time over the 7 days, decreasing steadily each day, with the highest amount of elution seen at days 1, 2, and 3, diminishing substantially in days 5, 6, and 7. In both cohorts, you can see that the active rate had the higher amount of elution at days 1, 2, and 3. In the vancomycin cohort, it's a little different. You can see on the left, again, the 1.5 millimeter sutures. On the right, you can see the 2 millimeter sutures, and it presents a much more steady state elution profile, particularly in the 1.5 millimeter sutures, whereas on the 2 millimeters, while it is consistent, there's quite a bit more fluctuation. So ultimately, what can we conclude? Well, for one, this is more of a proof of concept study for us, but we were able to show that there is a reproducible method to coat these commercial high-strength sutures in doxycycline and vancomycin that subsequently elutes over time. And two, we were able to measure consistent elution rates over 1 week. The question now becomes, from our point of view, how can we apply this in a clinical context? Can we identify high-risk patients and potentially come up with a way to expedite and augment the elution process or the dip coat process so that we can make a day-of decision for intraoperative patients? And that's where we plan to go with this. And thank you very much.
Great, thank you. So next presenter is from our institution here, Dr. Alex Hoffman, intraoperative evaluation of sarcoma surgical margins with indomyosin green fluorescence imaging.
Can I have some help? Good morning. My name is Xander Hoffman. I'm one of the lab PGY2s here at University of Pittsburgh. I'm going to be presenting the intraoperative evaluation of sarcoma surgical margins with indocyanin green fluorescence imaging. Thank you to my co-residents and to Dr. Weiss, my faculty mentor. No disclosures. So sarcoma is obviously one of the most important pathologies that orthopedic oncologists treat. And unfortunately, even despite improvements in treatments over the last couple of decades, mortality rates have been fairly stagnant. Surgery is still the foundation of sarcoma treatment, and obtaining negative margins is particularly important because obtaining a negative margin is associated with lower local recurrence rates as well as mortality rates. Across the field in oncology, evaluating intraoperative margins is particularly important. There's not very many good ways to do that, but one that's on the rise is fluorescent imaging, particularly with the use of indocyanin green, which is ICG, which is a fluorescent dye. It's currently being used throughout oncology, and here are pictures of gastric cancer. It's also used in lung cancer, other GI cancers, breast cancer. So our purpose of our study was to understand how ICG would be used for evaluating intraoperative surgical margins in sarcoma. So this is a prospective observational study done between April of 2021 and April of 2024. We included all adult patients who had concern for sarcoma based on imaging and or biopsy, who were going to undergo a wide resection. We excluded patients who were pregnant, those with kidney dysfunction, those who end up having a benign pathology on their pathology report, and those with insufficient video footage. We gave them ICG based on weight, so the weight-based dosing, 2.0 to 2.5 milligrams per kilogram, and we gave it 2 to 3 hours prior to surgery. We used a SPY-5 fluorescence camera, which is by Stryker. So this is basically how it works. So you resect the tumor. In the top right-hand corner, you can see one of those, and you visualize the entire tumor with the SPY-5 camera. When you do this, you're going to pick up the area with the maximum fluorescence on the actual tumor itself, and you set that as an arbitrary 100%, or the maximum fluorescence of the tumor. Then you turn to the tumor bed, which is the bottom right-hand corner, and you visualize the entire tumor bed with the camera, so you can find an average background fluorescence. And within the tumor bed itself, you look for the area with the highest amount of fluorescence, and that's your maximum fluorescence, so that you can determine a signal background ratio. So this is basically looking for areas that you're concerned for potential positive margins within the tumor bed itself, and it's relative to the tumor. We use the pathology report as the quote-unquote truth for what was a positive or negative margin. The surgeons also filled out a questionnaire where they subjectively were able to say, do I think that this was a positive margin within this tumor bed, or was it negative? And then we did an analysis with sensitivity, specificity, positive and negative predictive value, and accuracy to look at various signal background ratios and for the surgeons. So these are our results. So ultimately, 51 patients were included in our final analysis, about half and half, male and female. Primarily soft tissue sarcomas, about 80%. About 20% had prior chemotherapy, about 31% had prior radiation, and then our local recurrence rate of the 51 patients was 7, so 13%. And that was based on a 6-month to 36-month follow-up. So this is a lot going on this slide, but ultimately we looked at signal background ratios at various levels from 1.3 up to 2.1. The biggest takeaway here is that signal background ratio in ICG use is highly sensitive, and so as we increase the actual signal background ratio, it lowers the sensitivity, so they're inversely correlated. Conversely, surgeons are actually highly specific, so they're very good at seeing when they think that the margins are going to be negative. We also looked at local recurrence, and so similarly, we saw high sensitivity amongst the signal background ratios at low numbers, and then it was high for specificity among the surgeon. Interestingly, fairly high for the pathology, both for sensitivity and specificity, which makes sense because if you were expecting that you would have a positive margin, it'd be more likely associated with a local recurrence event. So in conclusion, we think that ICG is a potential very effective tool at evaluating surgical margins for sarcoma resection intraoperatively. Specifically, we thought about using 1.5 versus 1.7 as our cutoff. And obviously we can't, based on this study, since it's observational, know how ICG could be used to actually affect outcomes in patients. But I think a further multi-institutional, large longitudinal study would be needed to decide how ICG could be used and how it would change treatment outcomes. Obviously, limitations, like I said, is observational in nature. This was non-randomized, so these were patients who, based on their imaging and or biopsy, were chosen from our clinic. And then, of course, there's multiple patient factors and tumor factors which can affect these outcomes. ICG in particular, it's used based on, the tumor's hypervascularity and increased perfusion. And so, depending on the type of tumor or the patient factors, could affect that. And of course, we had a short-term follow-up on this. Thank you.
Excellent. So the final presentation for the morning is Dr. Kira Smith from Case Western, Comprehension and Satisfaction with Informed Consent for Arthroscopic Procedures Using Supplemental Online Educational Materials.
Hi, good morning. My name's Kira. I'm a first-year resident at UH Case Western. I'd like to thank my co-authors as well as OREF for having me today. So we have no disclosures relevant to the content of this presentation. Disclosures can be found on the Academy website. So the process of obtaining informed consent is a tenet of modern medicine, as well as a legal and ethical obligation of all healthcare professionals. We should be educating our patients on specific interventions, discuss the risks and benefits of the intervention, and assess for overall patient competency and comprehension. However, there's many obstacles to obtaining effective informed consent. So some of these obstacles, which I'm sure we've all encountered, include inadequate forms and documentation, patient gaps in health literacy, language and cultural barriers, lack of standardization across institutions and even within departments, and then time constraints and pressure. So we sought to improve the informed consent process by providing online educational materials to patients that they could then review on their own time. So the purpose of the study was to determine whether the use of online educational materials will improve comprehension and satisfaction of the informed consent process for knee, hip, and shoulder arthroscopic procedures. And we hypothesized that the addition of these materials would improve both the comprehension and satisfaction of our patients. So the 3 eligible procedures were knee, hip, and shoulder arthroscopy. Patients aged 18 and 89 were included, and then the exclusion criteria were anyone outside that age range or patients that English was not their first language. So any patients undergoing knee, hip, or shoulder arthroscopy were consented in clinic. If they agreed, they were randomized to one of 2 groups. So group 1 was the traditional informed consent process, while group 2 was the traditional process in addition to access to the online materials. On the day of surgery, prior to anesthesia or anything really going on, we assessed the patient's comprehension, retention, and satisfaction with a brief survey, and then we performed a chi-score analysis for comparisons between group 1 and group 2 within each cohort, so knee, hip, and shoulder. So this is just an example of what the online educational materials looked like, and I'll go through some of the information for the knee arthroscopy. So it's very brief and basic. What is arthroscopy? What is your knee anatomy? The benefits, risks, and alternatives of the procedure. And then this is what we asked patients the day of surgery. So all patients, regardless of whether they were in knee, hip, or shoulder, received this question. So you can see we have some general questions. How informed do you feel about your surgery? Do you understand the risks and benefits? And then for patients that were randomized to group 2, they also answered these questions here, specifically about whether they found the online materials useful or not. So these are the procedure-specific questions. So knee, hip, and shoulder all had about 10 questions, and we just asked patients to assess whether they were true or false. So for example, after surgery, will I have a large incision? Will a camera be placed in my knee during the operation? So kind of just basic questions about the arthroscopic procedure itself. So these are our results. We had 42 patients in the knee cohort, 26 in the hip cohort, and 28 in the shoulder cohort. The hip and shoulder cohort were evenly split between group 1 and group 2, while the knee cohort had more in group 2, and that's just kind of how they got randomized. So results for comprehension. So how informed are you about your surgery? So there was no significant difference in the proportion of patients who were very informed or extremely informed of their procedure for any of the cohorts. How clearly do you understand the risks, benefits, and alternatives of your surgery? So there was no significant difference for the hip or shoulder arthroscopy cohorts. However, there was a significant difference in the awareness of risks, benefits, and alternatives to knee arthroscopy in the cohort that received the online educational materials. So satisfaction. The online materials were useful. So 85% of the knee cohort found the materials useful, 62% of the hip cohort, and 90% of the shoulder cohort. How satisfied are you with the information and teaching that you received? So again, there was no significant difference in the hip or shoulder arthroscopy cohorts. However, there was a significant difference in the knee arthroscopy patients who received the online educational materials. So limitations, this is a small sample size. We're continuing to enroll patients and collect data. It's currently unavailable to non-English speaking patients, and with that, one of that being the barriers to obtaining effective informed consent, I think that would be a good direction. And then there's enrollment and patient bias. So again, in conclusion, the online educational materials were helpful for the knee arthroscopy patients, understanding the risks, benefits, and alternatives, and they were also more satisfied with the informed consent process. However, these findings were not seen in the hip or shoulder arthroscopy cohorts. Thank you.
Great. Can we have the presenters up on the stage again, please?
The tribunal.
My first question was for the first presenter, Dr. Degovia. Yeah. So I'm just surprised that there's no sutures that are already embedded with robotics currently on market. That's true?
Yeah, not that we could find.
Yeah. So if that's the case, what was your choice of the antibiotic? Like, what were the reasons for it, doxy and vancomycin?
Yeah, so we wanted something that was broad. Obviously, our thought process was like the most likely contaminant is usually skin flora, so we wanted something broad in that sense. And then we chose doxy partially for the antibacterial properties, but then one of the studies we looked at Granted, it was a rat study, showed that doxycycline had qualities where it inhibited MMPs and had enhanced collagen and fibrocartilage reformation. So it augmented rat model rotator tendon repairs. So that's why we went with the doxy as well.
Can I ask you a question? So, what is the infection rate in rotator cuff repairs?
Sorry, say again?
The infection rate in rotator cuff repairs.
It depends what you look at, but I've seen numbers as low as 7, and then some say as high as 15 to 20, depending on what statistic.
15 to 20%.
Yeah, but
of infections of rotator cuff repairs.
Yeah, but it was a small sample size, so it's much lower on average. Usually sub 7, sub 6%.
Do you have 7% of your patients infected?
Yeah, exactly.
So
he's like, they weren't infected when I saw them. They just were infected when they saw someone else.
So the reason why I'm asking that question is because we have that same discussion with ACLs, right? And there are studies out there that claim that 5% of ACLs have infections, particularly in high-level athletes. And if you really dig down into that, those are superficial skin abscesses or so in the majority of cases, right? So now you're using these sutures intra-articular, right? And I understand the desire to deliver antibiotics into it, but how are you ever going to prove that that makes a difference, right? Because the actual intra-articular infection rate after these procedures is in the promille area. It's not in it's not in the percentage areas, right? And you can never prove that point, right? So the difficulty here is, what is the recommendation that you give at the end? It's great that you can do that, right? And it's kind of actually interesting that you get different dilution profiles between the different antibiotics by sutures, which makes me think that you have to look at the mechanical stability of the sutures afterwards, right? Because these antibiotics go somewhere inside that suture in different kind of ways. But this is something that you will never be able to prove that actually will help.
Yeah, that's a great point.
Yeah, the suture things seems fascinating to me. I have no idea, how you use it in the clinical setting. But from the basic science point of view, you basically use the 2 antibiotics, right? And doxycycline.
Yeah, Vanco and doxycycline were the 2.
Okay, so one is probably stronger antibiotics. Okay. Now, how do you basically, I understand it, so you basically coded this, the suture. Right, yourself, right?
Yeah, we did in our lab.
How do you get a consistent, how much concentration there? Because we have to consider therapeutic concentration of these, any antibiotics in order to have, let's say, killing the bacteria, right?
Yeah.
How do you control the process?
Yeah, I mean, we controlled it as best we could. We started with solid antibiotics and measured out the exact amount and then diluted it and then used that dilution solution to impregnate the antibiotics or impregnate the sutures and have them saturate for the same period of time. So, there is an element of variability there, but we tried to control it as best we could in terms of how long they soaked in the dip coat, which was about 10 minutes per suture per antibiotic solution. So it's the same period of time.
I see. Now, for the next steps, since it's not on the market, so are you going to kind of continue working on it and prove the efficacy and also safety?
So that's kind of like I said, this was very much proof of concept for us. And to Dr. Latterman's point, that's kind of where the roadblock we're at now. We're trying to figure out what the next steps would be in terms of clinical use and clinical application, but more importantly, kind of coming up with a way to demonstrate clinical application and clinical efficacy. And that's kind of the roadblock we've been at for the last couple months.
All right, thank you.
This question is for Dr. Smith. Some of these educational materials, I think, are really important as care kind of transitions to things like ambulatory surgery centers, like how do you make sure that a patient is going through the whole episode and understands what's going on in a sort of very succinct way. And I think the way we convey information now is very different. If I give somebody a pamphlet, particularly, I think the Gen X or the Gen Z generation, nobody looks at pamphlets anymore. It just goes like straight to the trash, right? So so you give patients online materials, so you're expecting them to kind of read them online, or sort of, you know, one question I have is why is there discrepancies between sort of the different procedures? That seems to not make a lot of sense. I don't know if it's a statistical anomaly. And second is, you know, what methods do you think you might improve on that method from trying to get, you know, this information conveyed to them in a more succinct and sort of clear way?
Yeah, I agree. I don't think I have a great answer as to why there is some differences, but what I found interesting was our shoulder cohort, the average age was older than the knee and the hip, and we didn't statistically compare the demographics of the groups because we didn't feel that that was the main purpose of the paper. But I found it was interesting that 90% of that population, although they were older than the other two cohorts, still found the online educational materials very helpful. And I thought that was interesting because our hip arthroscopy cohort, which is traditionally much younger, didn't find them as useful. So I think the next kind of steps would be to look a little more into why that may be. I think another possible reason for some of these things is we consented patients for any type of arthroscopic procedure, and I think there is probably some differences depending on what type of arthroscopic procedure you're getting. For example, you know, when patients get ACLs, I think ACLs are very well understood to the general population compared to maybe like a meniscectomy. So I think there could be some differences in that. Can you repeat your second question? Sorry.
I don't even know if I remember it anymore, actually.
I got a second question for you. Again, with the consent process is really interesting to me because there's so many factors that go into educational levels, the language that we use, and there's so many different things that we discuss too. And big categorically, you talk about the risks and the benefits of surgery and your options of having surgery versus not surgery, versus patients understanding what the procedure is. So my question was, you went through your online education a little bit. Did it really focus on both of those categories, or did it have, you know, because some of the questions were like, did you understand the risks and the benefits, which is a much higher level of educational sort of content versus, you know, do you understand what a knee scope is?
Yeah. So I didn't include images from the entire online education that we provide with the patients, but it does go much more into detail about some of the risks and benefits of the procedure. I just didn't highlight it today just because I wanted to be more concise, but it does go into more detail on the website.
So many questions. No, but you have answered a couple of those already really well. But, you know, so did you look into the time that a physician takes to do the consent? Because I do cartilage repair, for example, right? And my consents on average take almost 10 minutes. Versus my colleagues who only do meniscectomies, their consents takes like 2 minutes. Right, and I would assume that between hip, shoulder, and knee, there's differences here. And I'm absolutely certain that if you do a 2-minute consent, that you're losing your patient somewhere. You know, so did you look into that at all? If that has an influence, because that's the only thing that I can come up with why there would be a difference between knee, shoulder, and hip.
Yeah, I think that's a great point and something that we would definitely want to include as we continue to collect data and eventually write the manuscript. I will say that we have multiple surgeons contributing patients to basically all of the cohorts, really, except for the hip arthroscopy group. And so I agree there's probably a lot of differences in how our providers are consenting their patients in clinic, what the clinical practice looks like, what maybe the time constraints or the infrastructure are. So I think if we looked into that further, it definitely could play a role.
This is for Dr. Smith as well. I've been on a data and safety monitoring board for NIH since 2004, and part of our role with the DSMB is to, for those grants that we're reviewing, to initially also look at the consent, informed consent documents. It is amazing what's happened since 2004. I mean, when we first started, these consents, some of them were 100 pages. And our comments back to the grantees was, nobody's going to understand this. It's just too much. they've evolved. They're a little bit shorter, but still it's overwhelming to the patients. So I'm curious, this online program that you have seems like it could be an answer for it. Are you seeing this being implemented elsewhere, or are you the first to give this a shot?
So full transparency, I don't know if it is being implemented elsewhere. Some of the next steps that we wanted to take at our institution were expanding it to other elective procedures, as well as maybe some less elective and more emergent procedures, to see if that makes a difference. You know, all of these arthroscopy procedures, they're getting their surgery dates scheduled sometimes months to weeks out. So that gives them more time to kind of sit with the online educational materials if they are utilizing them. So I think it would be interesting to see if we expand this program to include more surgeries and include more, I guess, patient populations, if that changes anything.
So one last question is for Xander. So, you know, the technology that you presented is obviously very promising for something like tumor, where you're really looking at life and death scenarios. Can you educate us a little bit? So a dye of this nature, is it better to be specific or sensitive with a test like this?
So I think that in the results of our study, you know, you can tell that the surgeons are very specific. And so I think that ICG used on its own, I think actually isn't very beneficial. I think it could be used as a tool by surgeons to basically assess areas that they could be concerned that, hey, this might be an area where I may actually have a positive margin. Because I would say in general, you know, when an orthopedic oncologist finishes their procedure, they're, most of the time, obviously, they're intending for the margins to be negative. So they're not assuming that they would be positive, you know, except in the case of tumor debulking and other specific instances. So I think the ICG, particularly in the cases where, you know, they're like, oh, I think on this side, maybe there might be a small spot. And oftentimes, you know, if you were to use, you know, intraoperative sections, frozen sections, that's very much more time intensive, and particularly with a lot of the large procedures that they do. I think that ICG is a great option because basically they get this dye preoperatively, and I think that in terms of the actual larger study that would need to be done for ICG to be something that's used frequently, we would need to look at actually preoperative timing in terms of ICG when it's given. So there have been, you know, studies that talk about it being given the night before and getting patients to be admitted preoperatively. But I think that'd be very challenging for a lot of patients to actually want to do. But it's a very simple thing that, you know, at the end of your assumed resection, you can just take a camera and look at the surgical field for 5 minutes and then say, hey, I think we're good. Or if there's a spot that, you know, maybe you were concerned about, you say, hey, this spot actually is lighting up a lot more. Then, you know, that could be something that could definitely guide and I think reduce the chance of a positive margin and local recurrence and mortality.
Xander did a great job answering your question, but from my standpoint, ICG is doing what I want it to do because I want it to be sensitive, right? As we've learned, surgeons are plenty specific in that when my margin's positive, I know it's positive, right? When we first started the study, we set it up as like a contest, right? We have this detector and we have the surgeon's experience. Which one is better? Turns out that was probably stupid because I and the machine are good at different things. The machine can see things that I can't, right? Whereas by virtue of my experience, I know things that the machine doesn't. So so that gets to the first part of your question, which was what's better for the machine to be sensitive or specific. The reason why I think it's better for it to be sensitive is because if it shows me a high number way out in the periphery, I can say, I was a mile away. Forget that. It's nonsense. That's a false positive. Whereas if I'm looking next to the bone or the periosteum or the femoral artery, you know, dang, I knew I was close there. Maybe I need to send a frozen. Maybe I need to activate my colleagues in vascular surgery. So as we move forward, what I'd like to do, and I got to learn a lot about writing clinical trials, is how do we put the chocolate with the peanut butter, right? How do we Because we're not as good as we think we are. If you look globally, the local occurrence rate is 20%. That is not acceptable. So how do we put my expertise and my partner's expertise with a machine that is completely objective and really sensitive to bring what we're best at to the benefit of the patient? So I think that's probably the next step.
All right, thank you guys. Please give them a round of applause. It was a great presentations. I think we'll take a quick 5 to 10 minute break. All right, well, thanks everyone again. Great presentations from this morning. It's really my distinct pleasure to introduce our guest speaker and our keynote speaker for this event, Dr. Christian Latterman. Dr. Latterman did his medical school training in Germany, and we had a lot of colorful conversations last night for dinner about his experience here, coming as a research fellow, essentially, with Dr. Fu for a number of years here before he became a resident. He's one of the first sort of international residents who have gone through our program, and he really paved the way for a lot of our many distinguished international residents who have since graduated the program and done really, really great things. And so after he did his super chief year, he then did his fellowship at Rush, and then he spent a number of years at the University of Kentucky, where he really established a really robust cartilage research center and has done really prolific work. And then in 2018, Dr. Kang, as many of you knew here, became the chair at the Brigham and then recruited Christian to become the chief of sports there. And since then, he's done really, really great things, expanding the program, continuing the cartilage research. And he's one of the most world-renowned researchers in cartilage. He's actually the president of ICRS this year. He's also been a really, really great friend to the University of Pittsburgh. And so it's really my distinct pleasure to welcome you, Christian, and on behalf of Dr. Hogan and the Orthopaedic department here at UPMC, thanks so much for coming.
All righty, is this working here? Do I need to switch this on and share? All righty, can you guys hear me there? Yeah. All right, perfect. Excellent. Well, thank you very much for having me. It is a truly great honor for me to be here. Yesterday when I was flying in from Boston, I actually flew a fairly unusual route right over Regent Square, right over Oakland, and then straight in. And there were so many memories that came back. All my kids were born here. I met my wife here. In fact, the first day that I showed up, it was April 1st of 1997. I arrived as an April Fool's joke, and it's been going on like that since. And I had so many mentors, friends, colleagues here over the years. So this truly feels to me like a homecoming. And thank you very much for having me. And also thank you very much to the OREF for hosting this and for having me as a speaker. And what I want to share with you guys is a little bit of a journey, right? So physician scientist, this is what you guys all look at. That was something that I had kind of sort of very early in my career. I knew I wanted to be a scientist. I knew I wanted to do research. That was important to me. But at the same time, I come out of the surgeon's household, and I also wanted to be a surgeon and take care of people. And that pathway as a true physician scientist didn't really exist back then. And so as we went along, it kind of sort of a lot of the things you pick up along the way, and there's a lot of successes, a lot more failures, and some of this work I want to share with you guys. Oh, now it switched it off, I guess. There we go. Okay. Good. So if you look at this is a little bit of a kind of sort of my pit journey. I was a resident here. I finished in 2005 as a super chief with my super chief class. Down there, some of you guys may recognize that little dinosaur in front of the cathedral. Freddie Fu was my mentor pretty much from the day that I got here, but there were so many others here in this place that really were instrumental in who I am today. And again, I want to thank you guys for that. So I'm talking about osteoarthritis, inflammation, and its resolution. So this is really a research journey full of surprises and insights. This is one of the most beautiful pictures I have ever seen, and this is why I went into sports medicine, because there's nothing prettier than a normal knee. Right? So when you're looking inside the arthroscopically, this is a completely normal knee. This is a 14-year-old. The problem is, this is what happens with it if it gets injured. And that can happen actually fairly quickly. And when I first started, basically, we were fairly ignorant, and we were thinking basically, oh, you know what, when I have these ACL injuries and whatnot, we'll fix them, you'll be good and new. Right? And yeah, not really. And then as I was developing my career in Kentucky, I realized more and more this is a fairly natural course what you see here. Right? You see on the left, this is at the time of ACL injury. On the right is 18 months later, same joint. Right? So in 18 months, he basically broke down his entire lateral condyle. Why does that happen? So we do know that ACL injuries lead to cartilage damage, right? We've all seen these very typical bone bruise patterns, right? And Hollis Potter at HSS showed us in 2012 that every single one of these bone bruises will lead to a cartilage defect. The question is how quickly and how badly, right? And that we have never actually really been able to figure out. We could not figure out what really determines how bad that defect is going to be at what time point. But what we do know is that with a very high certainty, and you're looking at odds factors here, an odds factor in the 20 or 50 range, that is unheard of in orthopedics, right? And so in other words, if you have an ACL tear, you will have a cartilage defect. That is pretty clear, right? And, we learned that. Unfortunately, what we also learned is that it's not just at one location. When we looked at our cohort back in Kentucky in 2010, not only did we see that the ACL injuries kept creeping up further and further in a fairly young age group, as you see here in that red circle, but also there is these innocuous cartilage damage elements that happen in every single one of these patients on the tibial plateau, on the femoral condyle, medially, laterally, etc. So in actually also the patella. Right, so they are concomitant to the injury. And if we see the most recent data is we are not actually doing a great job stopping these injury frequencies. In fact, it's getting worse, despite all the injury prevention programs, etc. So the problem here is we are not solving this problem as of yet in terms of how many of these patients we see. And we know that there's a large number of kids that will end up with osteoarthritis in one way or another. So this is the bone bruise. Well, the bone bruise is an area where you have a significant compression injury on the femoral condyle and typically correspondingly on the tibia, typically posteriorly. And we know from Connie Chu's work out of Pittsburgh here that impact injury will lead to cartilage damage. Right? So this here is damaged cartilage. And that undergoes a progressive decay, right? This is a little bit like Detroit in the last economic crisis. Maybe the next one is just about coming. And what you see is initially the articular cartilage looks fine. However, the chondrocytes that live in that articular cartilage, the family that lives in that home up top, is moved out. They died. Right? So the house will be fine for maybe the first 6 months, and then you come back at 1 year, and then the windows are broken, and if you come back at 3 years later, basically it's all overgrown, the roof has issues, and the same thing is happening with the articular cartilage. So your matrix maintains itself for a while, and then it breaks down. And that is exactly the reason why it takes so long to develop, and this is why it is so hard to find causality. Inflammation is a driver here. And that was one thing that we started realizing actually kind of around 2010, 2011. Before 2014, osteoarthritis was considered a non-inflammatory disease. right? So this is fairly recent that people actually acknowledge that. And we all know these statistics here. This osteoarthritis does lead to clinical consequences for young individuals. So if you look at the joint journey, we typically have our little athletes. Sorry. We typically have our little athletes. They have an injury. That leads to an inflammation, we know that. And a lot of them basically then have their surgery, go back, and then go back into that cycle, and may re-injure themselves even, or may even do it 3 times. And then we give them an award for the comeback athlete of the year, right? But some of them will go on and progressively get worse and worse and worse, and have chondro damage, then early OA, and then they are getting to the point where they have progressive OA. So if you're looking at the classic example of how healing happens, and this is a classic Anderson slide, and you see that first mount, the inflammation, happens early on and then it disappears. The problem is, what happens if you look at the 10 days after wounding, the inflammation is gone, right? But in these first 10 days, you have an entire group of cytokines, inflammatory, anti-inflammatory, et cetera, that are acting. Now, this is not something that happens only in the acute situation. That can also happen chronically. And we looked fairly early on we were trying to do a different kind of study, but this is what we ended up here doing, is we looked at our athletes and tried to follow them through the season for certain cartilage-related parameters to see whether the cartilage actually gets progressively damaged based upon loading, overloading, and overtraining. And what we find is that high-impact sports clearly do that. You see that on the left. Versus low-impact sports like cycling don't. Right? So there's a clear correlation between the impact that a joint sees cumulatively and a response of the joint. Now, when we first saw that, we were very excited to say, well, it's like, this destroys the joint, so you have to get away from that. But some of that is simple, naturally, an adjustment that the joints does in terms of overall turnover. Then comes, the West Point study, Steve Swoboda, and basically says, listen, in West Point, they have an insane amount of ACL tears, right? Almost, I think at one point, 30% of their recruits got ACL injuries. And what he found was that there were certain measures that you could take in the peripheral blood that were already elevated at the time of enrollment at West Point, and that would be predictive of whether they do or do not go on to tear the ACL. What that indicates is that there's clearly a higher injury risk if you have certain impact parameters that you can measure actually in the peripheral blood. And that was actually very eye-opening because we realized that overtraining is a contributing factor to ACL injuries. Right? And this is not an old concept, right? And so this is a study that we did. This is a very small study, but it was really interesting because you see on the graph up the top left, you see the 2 time points on the solid bar. Those were the averages in terms of our serum comp measures that we got at 2 different time points during the season on female soccer players. And then there was this one point up top that was sky high, and that patient tore her ACL. But that measurement was actually the day before she tore her ACL. Right? So she already indicated that. We had no idea. That was just pure luck because I literally did the blood draw on her, and the next day she goes out and practices and tears her ACL. But that was the value the day before. Right? And that's basically an indicator that you can actually function outside of your normal envelope. This is an old concept that was propagated by Scott Dye out of San Francisco. If you function outside of your envelope of function, you are putting yourself at very high risk. not only for ligament injury, but also for articular cartilage injury. And we were recently able to show that there's a correlation of higher impact intensities with injury frequency in a larger cohort, and that also correlates with some of the markers that we have measured. So that is a fundamental thing that we need to understand. So this is really important to look into things like performance training on some of our athletes, rather than just basically telling them do more, more, more. Now, the other thing that we learned in those early studies was that biomarkers sounds great, right? It's like, hey, we have this biomarker database, we have all these biomarkers. Well, actually, it was Michelle Cameron here in Pittsburgh who did the very first study on biomarkers in OA after ACL injuries. And she generated a lot of data that was of real high interest, and there was actually some of that data was what drove Chris Evans to look specifically into IL-1 as a driver for arthritis, and that actually ended up leading to his first human trial in gene therapy using IL-1 receptor antagonist protein. The problem with that study is what you see at the bottom. These were just spot checks on a very diverse patient population. If you look at 10 patients 2 days after injury, the bottom is the spread of your IL-1 values that you get. So single data points for biomarker analysis are completely useless, because the spread is so wide you will never get any statistical relevance on anything. So you need longitudinal data. And to try to stick a needle into somebody who is 14 years old and just tore the ACL 4 times in a row, that's not an easy feat to do. So the recommendations right now is, and this is the official recommendations now 10, 15 years later, is basically you really need longitudinal data, otherwise your biomarker data is completely useless, right? So it took us 15 years to do that. Congratulations to ourselves. So if you are looking at osteoarthritis as a disease process, this is a disease that starts at the time of injury when it's not visible. And it leads to total joint failure where you need a total knee at the end. The problem is that when you're looking at where we are actually intervening, which is typically here, it's already almost too late. So if you want to change something substantially, you need to shift the frame. You need to look much, much earlier on, right? And this is where the biomarkers are an interesting idea, because they are a way to do that. So we designed a clinical trial trying to get at that. But if you're doing a clinical trial, anybody who has done that, you cannot just do a clinical trial to look at certain things. You actually have to offer an intervention. And that intervention has to be a benefit to the patient. So how do you do that? How do you explain a benefit to the patient when you're sticking a needle into their knee 4 times in a row in the first 6 weeks? Right, so you have to inject something into it. And what we actually wanted to do is we wanted to do Chris Evans's work as our kind of sort of background, and wanted to use IL-1RA in order to block interleukin-1, which is the obvious first anti-inflammatory cytokine that comes up right after injury. Problem is we could not get this through the FDA. What we could get through the FDA, interesting enough, and actually didn't have to go through the FDA, but had to go through a data safety monitoring board, was cortisol. So now a lot of you guys go like, oh, wait a minute, cortisol, right, in an ACL knee. Infection rate, you know, it's bad for cartilage, all these kind of things. So it took me 2 years going to pediatric societies and several others to try to find out what is actually true about all this. And it turns out triamcinolone acetonide, which is a particular type of cortisone, Kenalog, actually has never been documented to be either detrimental to articular cartilage, nor does it actually truly result in a high infection rate. Because a lot of that data that we are getting is based upon large industry, insurance databases. And insurance databases are very good to pick up certain things, But if you are actually looking at that specifically, and we had to do a small study, and then that turned into a very large study that Kurt Spindler subsequently published, where the administration of intra-articular cortisone at the time or just before ACL surgery does not lead to a higher infection rate. And it also, just between us, Kenalog does not destroy articular cartilage. I can go into depth on that. I've actually done a video for one of the WUMIDI or something like that on that. That is also bad data interpretation, right? But, so long story short, we used it. And what we did is we designed a trial where we had 4 groups. We injected one group twice within 2 to 4 days after injury, and within 10 to 14 days after injury. Another one just at the first time point, another one at the second time point, and another one just with saline. And what that allowed us to do is A, find out what cortisone potentially does to drive down the early inflammation, and B, what the timelines on all of this are. And this is what we found. So the gray bar is the control group. And what we are looking at here is CTX2. CTX2 is a collagen breakdown product indicating structural collagen loss. All the injection groups did a lot better. And if you're looking at the interleukin-1 data, completely knocked down. All the inflammatory data completely knocked down in the knees that got the injection. We were just like, that's interesting. Didn't really expect that, to tell you the truth. But at the same time, we got multiple time points of biomarkers that I'll share with you in a second. What happens right after ACL injury, and then before surgery, and then even after surgery. We did a second trial where we intervened after surgery. After surgery, I was not comfortable giving cortisone because it has effects on bone healing. And those are well documented. So we used an HA product, which in the end did not really do much either. But we got our data post-operatively now for longitudinal biomarker follow-ups. So this is what we found. We found that you have initially, right after the injury, a very high inflammatory stimulus. Interleukin-1 is sky high, IL-1RA is actually fairly low. And at the same time, you have significant articular cartilage breakdown on all levels. Collagen, CTX2, collagen breakdown. NTX1, the subchondral bone plate articular cartilage interface breakdown. And also for the matrix, MMP3. So all 3 elements of your articular cartilage are being affected here. And the other thing that we found is if you have very high inflammatory markers at the initial time of injury, it will actually have effects downstream. So about a third of the patients we know are painful at 2 years after ACL reconstruction, no matter how well you do them. And that does correlate with some of these markers. So there is a population where the initial inflammation drives postoperative outcomes at 2 years. And we were just like, well, 1/3, really? Is it 1/3 of our patients that are not doing that well after ACL? It's like, what am I all looking at? I remember Freddie's clinics basically, hey, you do great, huh? Everybody fine, right? And my own clinics where it's like, yeah, how are you doing 1 year after ACL? Fantastic, back to sport, yeah, let's go, right? The problem is that's actually not true, right? And, one of the big questions here was, where is this actually going with those knees, right? And so the second study that we did, we found that, first of all, we verified our triamcinolone data, and we found the same thing again in the second study. So now I believe it. And then the other thing that we saw is, unfortunately, right after surgery, everything starts up again. So even though if you are mitigating it early and you may have an effect at 2 years, but the surgery gives you a second hit. And that was a big thing because people have been postulating that, but nobody has actually been able to show that. And we were able to show that, and that's the front piece to the very famous studies that Stefan Lohmander published in the Canon trial, where he followed ACLs for up to 10 years, and he followed inflammatory markers and could show that any ACL will lead to a chronic inflammation no matter what you do. even if you tear your ACL and you don't have surgery, you will have a chronic inflammation. In fact, actually, you will have a little bit less chronic inflammation than if you have surgery, which for me as a surgeon, I was just like, oh, well, wait a minute, that can't be the case, right? Yeah, unfortunately it is, right? And part of that is because of that second hit. And we were able to show that this doesn't only happen with ACLs. This happens with knee dislocations. This happens with tibial plateau fractures. This is universal. Joint injury leads to chronic inflammation in the joint, and that leads to joint breakdown eventually. So there is fast and slow progressors. That's this 1/3, 2/3 group, right? There's some where we know that these markers are really high and those progress fairly fast towards painful knees. And then there's others that don't. And they divide about into 1/3, 2/3. And interesting enough, this is not just us finding. This is pretty much any cohort study that looks at patient-reported outcomes. This is Ivarus's group. They all have about 30%, the Moon group, same thing. 30% of their patients do not meet pass at 2 years, right? So, you know, this notion that everybody is just doing great because we put such a beautiful ACL in there is not true. And we also know that when we are looking at synovitis at 3 months, it does influence a lot of their, you know, pain inhibition, right? So it is the chronic inflammation that really drives that. So we defined this inflammatype in those type of patients. And that is the type of, that actually is a great research handle, because now if we can define who is the person who is at risk of not doing well, that's exactly the population that you want to study if you want to intervene, right? And then you don't have to study all 100% of the ACLs, you only study 30% of them, which makes it much, much easier to try to enroll people. So if you go back to our joint journey, you have your injury prevention programs. We're doing well with those, but not well enough. You have your surgery. I submit to you, it doesn't matter how you do your ACL. If you're doing it anatomically well, the way Freddie taught us, it doesn't matter which graft you use, it doesn't matter how you do it, your knee will do well from a stability standpoint. But it will not do well from an arthritis standpoint. Some of them do better than others, but none of them do great 10, 15 years out. And so we have inflammation still being an issue, right? That is not solved. This is why it's red. And then about some people, this is about 2/3 of the journey, right? Where the inflammation will kind of sort of mitigate, they get back to activity, et cetera. They stay in that circle. But some of them don't. They then go on to progressive condyle damage. This is where I sit. This is where I do cartilage repairs, et cetera. Right? And this is part of the reason why I like this, because this is exactly my home. But I also know that we are not doing perfect. We are not doing you know, a great job returning these people back to athletics, and we are far from 100% successful. Now, when you're getting into that range, then we are starting to run out of options. And back here, you get a total knee. But if your patient is 38, that's a hard one to sell. And so remember this chart here? The chronic inflammation. So if you look at Anderson's chart again, how we understand inflammation, remember I was pointing out this point here? That postulates that inflammation goes down to 0. That's actually wrong in the joint environment. And so if you look at this more carefully and you look at inflammation, there is an actual process that resolves inflammation and is supposed to do that. It's an active process that we are not typically taught about, at least I wasn't. If that process doesn't happen, you'll get a chronic maintained inflammation. And this is how this goes actually, right? So you have the initial immediate response, which is basically, you know, your interleukin-1s, your prostaglandins, et cetera. That's typically what we are trying to basically break through with NSAIDs, right? The so-called icosanoid storm after the injury. Now, keep in mind, that's actually important because it actually starts a secondary process that will lead to the expression of factors that are necessary for the resolution of that inflammation. So this is a physiological process. And then we are talking about things like SPMs, lipoxins, maresins, and others. These are all things that are not typically in the common mind of people understanding kind of what we are doing surgically. But from an inflammation standpoint, really, really important. And if that step in the middle doesn't happen, then we have a problem. So it may be time to use a different playbook. And one of the biggest issues here is we just don't look over our own cup of tea, right? In periodontosis research, arteriosclerosis research, pulmonary fibrosis research, this has been mainstay for the last 20 years. We just don't look at this, right? And if you look at chronic inflammation, that's where you find the solutions. And so one of the things that we didn't understand until recently is this active process is driven by macrophages. And macrophages respond to completely different chemical stimuli than what we typically play around with NSAIDs and corticosteroid, et cetera. Why corticosteroids actually do play a role there. And there's pro-inflammatory and anti-inflammatory macrophages. And you want the anti-inflammatory one. This is a so-called macrophage switch between M1 and M2 macrophages. And that can be driven by 3 different mechanisms. The first one is an alpha defensive mechanism. That has to do with infections mostly. Then there's the Wnt pathway where you can actually modulate it. And then the third one is the one with special pro-resolving mediators, SPMs. Those are fatty acids. Think omega-3, right? And those are actually effector molecules that are actively used in that process of inflammation resolution. And there's things like maresins, resolvins, and you see them up there. So we looked into that in an experimental model, right? We've heard a little bit about the mouse ACL model earlier. I'm not using the terrorizer, we are just cutting it straight. But I took this back into the lab. That's what it's called. It's called the terrorizer. So I took it back into the lab and then basically looked at that, had our little mice lose their ACLs, unfortunately. And we were trying to find out, first of all, can we reproduce what we saw in the humans? And this is what we did on this slide. You don't have to look into that in special, but this is exactly the same that I showed you in terms of the human data before. It follows exactly the same pattern, right? They all get arthritis at typically between 28 and 56 days. Now, if you're looking at whether inflammation resolution actually plays a role, we were looking for maresin, which is one of the most powerful ones, in the healing process of these ACLs, and we actually did find it. It gets activated, right? So it plays a role here. And the other thing that we found is we looked for the maresin receptor, which is called LGR6, and that is also expressed. So both parts, the molecule and its receptor, are actively expressed in the process of post-traumatic osteoarthritis. So that was the first thing. The second thing that we needed to show, obviously, is does it actually kind of correlate with the arthritis level that we are getting, and it does. And then we are lucky because we have mice that do not have the LGR6 receptor. And those actually, when they lose their ACLs, have worse arthritis. So that also tells that, that does play a role here. And then finally, we were substituting maresin at different time points, and we could lower the overall incidence of arthritis quite significantly in these mice. So that process is a completely new window that we can look into to potentially mitigate post-traumatic osteoarthritis. And the coolest thing about it is you can probably do it orally, right? Because this is basically this is a chemical process, and the lipids work differently than most enzymes. It's a chemical process. If you put more in, you get higher numbers, right? And this is not necessarily a negative feedback mechanism. And then finally, and this is where I come to a close here, we actually looked into, well, how can you use that in a clinical setting? So now I'm taking it back into the clinic. And we found that SPMs are in very, very high concentrations in PRP. And we say, well, then we just need to inject everybody with PRP. That's wonderful, $1,000 for everybody, right? Well, the problem is, no, it's not in any PRP. You actually have to look specifically for where it's sitting. And we looked into that then, and we found that the SPM sits specifically in certain extravesicular vessels inside the PRP that you can precipitate. Right? And so now that, I think, gives us potentially an avenue going forward. And our next step is now to then start taking that into a clinical setting, because that's an easy one to do. Right? And PRP injections after ACLs in athletes are super common, and why not take that into a clinical trial? So the current approach is very reactive. We have heard that earlier today from MaCalus. The future approach should be proactive. Be earlier on your interventions, your talk. If you can bring that first and second hit together, you may benefit from that. Boost inflammation resolution, and what we'll have to do is we'll have to study that a lot more. So that's basically kind of my next kind of 10 years that I have in my career. So thanks for all the funding that we got. We need a fantastic group of people to do that, and you need a family that can hold up with that. And then you need individuals like Chilan, for example, and many, many of you who are really driving this, because I can't do this by myself, right? So this is always about the team. All right, so I think I probably went over time, but so I'll take some questions now. Thank you.
Your really good work has shown that even despite doing that, the inflammatory cascade still goes. And so where does the sort of the mechanical nature of surgery play a role into this?
Well, that's a foundation, right? Think about a car, right? You can't drive a car without the frame, right? The frame has to be solid, and then you can start adding all the other factors. Is that thing up here? Yes. So you need a foundation, right? And the foundation is a stable joint, right? So if you leave the joint unstable, we all know that. We have the clinical data. It gets even faster worse, right? So that is the premise, right? And this is where, as a surgeon, there's no question. If you have an unstable knee, you need to stabilize that knee. Or you need to make sure the knee doesn't get unstable functionally, right? Or we have copers, right, who just don't have an unstable knee functionally, despite the fact that they're missing an ACL. Those people are lucky, hard to identify, and few in between. But you can't leave an unstable joint and expect that this is not going to have effects on your already injured articular cartilage, right? You're just compounding the problem. So what we can do surgically, we can fix these. The problem is we are introducing an additional problem doing that. And that we have no solution for right now. So whenever I get this question, the answer is surgery plus. Right? Yes, you need to do the surgery when it's appropriate, but you need to add something else into it to mitigate the biological effects. And that we completely don't do currently. Check.
Chris, thanks very much. Fabulous work. I wish Freddie was still here, because he would probably tell you that the double bundle really does prevent inflammation if you could just look hard enough.
You know what? And I did in those mice, and I have to agree with our colleague from HSS. It's really pretty damn small.
Well, anyway, I still wish she was here. But anyway, towards the end there, it just sort of struck me that, when we cut our skin, it heals. We don't have to worry about anti-inflammatories for skin healing. Yet there's something about cartilage in a joint. And one of the things that's unique to a joint is that it has compromised vascularity and that it's reliant on loop capillaries. And what you just said about the PRP and some of the elements of the PRP being possibly protective, maybe you're delivering the products from the blood that don't get there when there's a when there's edema or the equivalent of avascular necrosis from the injury, the original injury. Is that far-fetched, or do you think that there's something about the macro environment of the bruise that is unique to a joint because of its limited blood supply?
So I think the fundamental difference here between a joint environment, and Ewan probably knows a little bit about that because it's very similar in the disc, and bone healing, which is basically kind of the epitome of basically, if you have good blood supply, you'll heal well, is that joints have tissues that actually don't want blood. Like chondrocytes, for example, hate blood. Right? And in the joint environment, it is the synovium that plays the role of the caretaker of the joint. And if the synovium is going haywire, your joint will suffer. You know, and this is really interesting. There's some older studies on hemophiliacs where there's a genetic component here too, because some articular cartilage is more resilient than others. And in hemophiliacs, there's three fundamental groups. There's those that basically get arthritis after the first bleed. There's others that get arthritis hardly ever, even though they had 40 bleeds. And then there's a lot of them that follow the middle path, right? And that was a fairly clear indicator, and this has been proven multiple times since experimentally and also clinically, that intra-articular blood is a bad thing for a chondrocyte. Right? So that is not the solution. Trying to get blood to the subchondral bone plate is a good idea, but the subchondral bone plate in most cases is not the culprit here. Right? It can be, but in most cases it is not. And so you need to address that chronic inflammatory environment which is driven out of the synovium, and that is our target tissue in the joint. And that you don't change with increasing blood flow. In fact, it has too much blood flow. Right? An inflamed synovium is full of vessels. What you need to do is you need basically somebody to come in and basically tell the synovium to shut up and get back to its normal homeostasis. And the question is, how do you do that in a way that is not just knocking everything down, which is what cortisone does. Right? And this is why cortisone is beneficial on the one hand, but not in the long term. That's the way I think about it.
Just kind of going along with that, in terms of history lessons, there's another surgeon scientist, beloved of Pittsburgh and Boston, who would have loved this talk, and that was Mencken, one of the first and foremost cartilage biologists of the last century, who was one of the first people to show that articular cartilage was more than just the slippery white stuff that lives on the end of your joints, that it has a biology and respires and all these things, which brings me to my actual report for the residents. Thanks everyone who came to Pittsburgh today, but pay attention to this guy. He's not going to say this about himself, but I've known him for 30 years, so I can say this. Pay attention to this guy. He's a superlative technician, but that's not what he spoke about today. He spoke about biology. What are the barriers? What are the unsolved problems? So absolutely, learn your craft, be the best technical surgeon you can be, but never stop being a biologist. And thanks for being here.
Thank you. Albert, do we have 10 minutes? Are you sure?
We absolutely have 10 minutes,
Sorry.
Christian.
You are the arbiter and you know best. All right, good. So I have a couple of other things that I wanted to share with you, and I'll be as brief as I can here. So how to balance research and clinical practice, right? I told you I'm a physician scientist. I've been a scientist at heart from the very beginning, even though I don't have a PhD, but I'm just dangerous enough in that field. And so this is a really, really hard thing to do today, right? Because the career as a physician scientist requires you to be a good, and not just a good, but the possibly best physician you can possibly be. That comes first. And that is really important because you are a physician. You will be judged by physicians. You will be valued and you will be looked at by physicians. If you are not good in that role, nobody will ever look at the research that he produced. Right? So this is really important. And this is a lesson that I learned from Freddie. Freddie kicked me out of my lab. I had my own lab, actually, at the end of 2.5 years working with him. He physically kicked me out of my lab when I became an intern, and I was furious. It was the best decision he ever made for me, right? Because I needed to become the best clinician I could be. So keep that in mind, right? Science is something that you learn, and then you take it with you, and you keep it applying to what you learn clinically. And then once you're in that position, but that you're ready to fly, then you unpack this, okay? So what can you do to prepare yourself for doing science? Because it takes time. On a clinical side, you have to become facile and menial tasks, right? Stuff that is just busy work, you have to find a way to do it faster than anybody else. So start learning how to become efficient. Become a really good surgical technician, right? I mean, we are physicians, but we are surgical technicians, right? That is something that at one point, if you really want to continue on to be a physician scientist, has to be a secondary thought for you. Worrying about how to do something technically, if that's the case, then you may not have the bandwidth to go and add an additional 40% of your workload, right? So make sure that that's what you focus on in your early training. Learn to be time efficient and learn how to deal with conflict. That's the other thing that nobody ever told me. The hardest situations that you are in are situations where you either are in the middle of or have to mitigate a conflict. Typically, of course, between people, sometimes at a higher level. But learn how to do that effectively and learn how to communicate effectively if you see that something is not working the way it should, because that can cost so much of your time and occupy you to a degree that may not allow you to do other things if you don't know how to handle that. So learn how to do that. And then understand your strengths and weaknesses. Work on your weaknesses. My weakness has always been data management. Excel spreadsheets, reference databasing. Oh my God. Like my daughter yelled at me the other day. And then play to your strengths, right? Don't try to become MaCalus. Don't try to become me or Kurt. You become your own person and you play to your own strength, right? Because you all have extraordinary abilities that none of us do. And it is how you put these all together that makes you individually strong and individually special. And then understand what the different roles are within a research team and who can direct and do what. You can't possibly do everything, and you will not be the best at everything. And trying to pretend to do that will destroy your team. Right? You need to basically, if I have a tough statistical problem, I'm not going to try to solve that myself. I go to the person who I know can do that in my team. If I have a design problem on a trial, I know just enough, as I said, to be dangerous, but I have somebody who is better at that. Use those people and admit it. Don't pretend you are the best and you are the boss of everything, so you know everything. This is an old-style concept that doesn't apply anymore. So become a team member before you're trying to lead. In terms of research, there's multiple different avenues that you can take. Personal advancement is part of it, right? But you can take the research in different directions, and you can use it in slightly different formats, right? You can either use it to advance the cumulative knowledge in your field, or to improve techniques or skills, or to innovate and do creative thinking. And we have seen examples of all three of these in the presentations today, which, by the way, I want to thank you because they were incredibly good. They were fantastic. I really enjoyed this. But it's also a very slippery slope, right? And the slippery slope is because you're constantly under pressure to produce, right? And if you look at the typical career between residency, fellowship, early and mid-career, you have the publish or perish guys. Those are the guys that you will never be able to out-publish. They come out of their residency with 50 papers. In the first, in the fellowship, they produce 60 papers, but they are all over the place, right? On shoulder, on ankle, on knee, on hip, on whatever, right? Well, that's not really much of a direction, but that's one way to get notoriety and to go out. They will burn out eventually. Then you have those that really only publish for the sake of what they have to do, and those go into the community. They are great physicians, but they are not researchers. And then you have the average academic career, which gradually kind of will keep publishing a paper, maybe 2, 3, maybe a year or so, and you'll gradually add that up. The physician scientist takes a different route. In the beginning, you actually will not publish a lot because you have to do a lot of thinking, a lot of designing, a lot of basically getting the basics in place. But once they are in place, it will take off. And then suddenly you are basically going to be out publishing almost everybody, right? And that from an academic standpoint, that is important to know, right? Because in the beginning you go like, oh my God, I only have like 4 publications this year. Like, you know, I'm not performing. Well, believe me, if you're going the physician scientist route, in 10 years you'll have 20 to 30 publications a year, and you don't even know half of them how they came out there, all right? So again, you can do tool technique development. That will give you recognition by your peers and possible IP. That's one way to go. And there's no judgment here. Some people really find that cool and interesting. I personally never liked that. It's too close to industry, too close to conflict of interests. That's a slippery slope, right? Because whenever true financial gain comes into play, that's a slippery slope for you as a physician and when you're doing science. And the alternative revenue source goes then into true intellectual property, which is also kind of sort of in that realm. If you are doing research to advance a field, that's probably a harder route to go because it's the long game that you're playing here. It requires funding, it's often deadline driven, consistent time commitment. These are not one-offs. It forces to collaborate with other institutions, researchers, and in Kentucky, I mean, believe me, in Kentucky, I mean, who the hell goes to Kentucky, right? Although I absolutely love that place, but I did most of that research that I presented was done in Kentucky, but my collaborators were at the Cleveland Clinic, in San Francisco, and at Duke. Right? And that's what you have to understand, that you can't do this alone, not even in your team alone. You have to have collaborative efforts, and that requires communication. And then the other thing is if you are interested and capable of doing this, it's fewer than 1 in 20 academic and 3 in 1,000 overall orthopedic surgeons have received an NIH funding. Right? So it's a really small number that you're shooting for there. So there's a choice, necessity, interest, or is it your calling? And there's, as I said, there's no judgment here. It's your call which direction you take and why do you do research. And any of it is good. A quick note about how to do this. So to do research like this, you work basically between 3 and 5 a.m., then do a full clinic, a full OR every day of the week. You go 100% in the evenings, you cover a game, and you do research on the weekend. Yeah, that's how Albert and myself and many others started out, and we burned out about 2.5 weeks later. This is unsustainable, right? You can't do that, right? It's often tried, hardly ever successful. The other way to do this would be like that. You do all your administrational stuff early in the mornings, you do your clinical work during the day, you do some admin in the evenings, and you do all your research on the weekends. Well, you can do that, just don't expect to have a family, right? There are some people who can make that work. That didn't work for me either. The other thing is, you have 20% of non-reimbursed work time here. Right, so that's basically your institution buying you out for 20% of your time. Most of them don't do that, right? And so what you need to do is you need to really become efficient at combining as much as you can, your clinical work with your research work. Right? And then you can shave off areas, right? If, for example, half the patients that you're seeing in your clinic are enrolled in your research projects, well, then you are combining this. And now suddenly you are double dipping into your time. And that is sustainable, right? So bring them together as close as you can. And that is individual to you and your interests. right? And that is why it is unsustainable to try to publish in shoulder, knee, hip, ankle, all over the place. You can't do that. You have to have a specific focus. This is why I am an orthopedic surgeon doing cartilage repair talking about osteoarthritis, because that was available to me, and that is why I could make my mark. So integrate those processes. And then out of this slide, the only thing that I want to mention here very specifically, whenever you work in those kind of teams, and this is something that Kurt Spindler taught me, check your ego at the door. It doesn't matter who the hell you are. Every single person in your team is as important as you are. And if they have a problem with something, you listen to that. Whether you are the big guy or not is dependent on everybody else. Right? So check your ego at the door. If you're in it for the long game, quick wins are just that. Every once in a while you get one and you do it and it's fine. You get a quick publication out of something that you didn't expect coming, but that's not sustainable. Look for the hard issues that are requiring an answer. When I came out, the big issues were patellofemoral, early osteoarthritis was coming up, articular cartilage. Those were the things that I was going after, right? Because a lot of people didn't have a lot of solutions to it. The hard questions are the ones where the physician scientist can basically delve into. You will not get quick fixes on this one, okay? And then if you look at this, 10 years, 100 articles, 1 or 2 strong clinical statements, right? If you look at my talk today, this is 15 years of research. And I have 2 statements at the end that I could make, right? But these statements hold up, and these statements are clinically relevant. So that's the course of a physician scientist. And then be your harshest critic when you publish. Make sure that what you produce is good work and not just okay work, right? Make sure it's the best you can do. And be careful, I mentioned that earlier, what you publish, because things will be used against you or your profession. Classic example is some of the meniscus papers that were coming out, or infection papers, for example, cortisone injections, for example, right? Now we are hearing, oh, you can't do a patellofemoral for 6 months after the patient had a cortisone injection. Well, where does that come from, right? That comes out of misunderstood literature that the insurance companies are using to create their policies. Right? And so those kind of things you have to be really careful about. It is very easy to publish out of large databases, but be absolutely aware of the fact that these large databases are flawed. And what you say in your conclusions matters. So life's like riding a bicycle. You need to keep your balance. In order to keep your balance, you need to keep moving. So be curious, ask the hard questions, have your eyes wide open and recognize when things are just too good to be true on the science side, right? And privately, make your private life a priority. Relax your mind with hobbies, right? If you can do physician scientist, you can have additional hobbies on the side, and you should, because if you only think into one little rabbit hole, your brain will shrink. Right? Go out. I go whitewater kayaking, right? Every time I knock my head, my brain goes way up, and it's like, oh, I see all kind of stars. It's a great universe, right? So, and be a good steward of your mind and body. Thank you.
That was outstanding, and Lee will join me. So I don't know what was better. I was getting excited about your PRP and biologics conversation. And then you close with that, and then just like, let's just turn the lights down and just keep going all night, right? That's great. Try to make sure I phrase this correctly. We'll get some pictures. So, as he laid out as he laid out your course for your future, I hate to say it, but in this world, as Freddie would say, there are always winners. There are not losers, because no one is a loser today. But we do have to, in order to bring people back and continue to enrich and invest in the future of research and the future of physician and surgeon scientist, it is always helpful to give out a little bit of paper, certificates, and as the residents like, cash, right? So so Leah and I will we will start with third place and up. So as a reminder, and those who are first and second place are the ones who will go on to nationals, correct? Did I, right? And correct. And so, and there are monetary awards with each of these, and I will announce it as we go. Yeah, and we have the presenters award first. Do that one first? Okay. Great. Starting with third place. Yes, yes. Good. All right. So, how about you hold these for me if you don't mind? Great, great. See, excellent. See, the team helping me, right? So great, and the humility to ask for help, all the themes. All right, so we will start with the presenters award. This will go to our very own, and this is not intentional. I hate to give out the first award to actually a Pitt person, but no. All that said, it will go to Alexander Hoffman for his talk on intraoperative evaluation of sarcoma, surgical margins, and endocyan green imaging. Now, is Andrew here? Oh yeah, that was your cue to start walking in this direction. So great. So we will get you on stage to take a picture here with Dr. Latterman. We need to be in those, and then
Congratulations.
Thank you. All right, you guys do the picture with him while I keep announcing. Yeah, I'm in enough pictures. All right, great. Oh yeah.
Just like that.
Oh yeah. Take this little tag off.
You
All
need
right.
to
After
show
you, after you, we'll have it down a little better.
Beautiful. All right, ready? 3, 2, 1. And one more for good measure. 3, 2, 1. Beautiful, thank you.
Thank you.
All right. Good job.
Okay, and the way this is structured, we have 3 third place, 2 second place, 1 first place. So we will start with the first of the third places here, okay? So from Case Western, the suspense rises since there's so many of you here. Alexandra Berk, speaking on patients with vitamin D deficiency are more likely to develop complex regional pain syndrome after extremity fractures, a large database propensity matched cohort study. Great job, buddy.
Congratulations. Well done.
Ready? 3, 2, 1. And one more. 3, 2.
Outstanding. So for our next third place, that will go, coming from University of Maryland, again, suspense, Alexandra Baker Lutz, her talk on the impact of obesity on patient-reported outcomes 2 years after multi-ligament knee reconstruction. Congratulations. All right, also awkward. First 3 winners all named Alexander or Alexandra. Right. So, but that's it. We love it. We love consistent outcomes. No, that's great. In the world of research, consistency is key. All right, great. The best part of this is I had nothing to do with it, so it's actually amazing. It's going to get better here in a second too. So great. We're going to go with our now we are going to, that was next third place. Yes. So our next third place. And shifting. All right. Again, from Case Western, Margaret Sinkler, to fix or to replace the analysis of geriatric periprosthetic distal femur fractures treated with OREF, retrograde IM nailing, or distal femur replacement. I really like that one. Congratulations. Thank you so much. Yeah,
Congratulations.
Excellent. There was a question about the amount of the awards. As stated, third place is 500. The presenter's choice is 600. Second place is 750, and first place is 1,000. So we will go to our second place. It will go to Zachary Herman from University of Pittsburgh. Overhead athletes have comparable intraoperative injury patterns and clinical outcomes to non-overhead athletes following surgical stabilization for first-time anterior shoulder instability at average of 6-year follow-up. Great job. Yes, yeah, exactly, yeah. I'm glad it took you a little while to get here.
Yeah.
Yes. So One thing I will add during this moment of comic relief, the residents know I'm actually quite serious or completely unhinged. But I will say you guys did a great job today with timing. I mean, the ability to put your talks together within that 5-minute range. We remember that when the Academy would have 5-minute talks. But I want to commend everyone in that because you did quite well. That said, in the future, OREF, definitely give a word limit on titles for future meetings, okay? Yeah, so you got to get these guys to start working on that. So, no, but great job. All right, next second place. Our next second place, then we'll go to first is, again, the lovely A. So Alexandra White from the Hospital for Special Surgery on the effect of posterior tibial slope on tibiofemoral joint biomechanics and in vitro analysis. Congratulations, Alexander. Congrats. Good.
Great work.
Outstanding. And so we have the moment of truth and our first place winner, also from the Hospital for Special Surgery, Julia Retzky, in her talk on early anterior cruciate ligament reconstruction mitigates the development of post-traumatic OA in the marine anterior cruciate ligament rupture model. Thank you. Thank you.
Great work.
I love that as well, as it was an acknowledgement of the fact that those rats did not undergo surgery in vain. So, hey, congratulations. All right, great. I am going to make one last request that is outside of, chair's privilege. I would like all the winners to come up and do just one more picture with the group as well and with the judges. If you do not mind, that would be great. Thank you. One more push to the front. I should have told you guys that before you went back to your seats. So if y'all could come up, you don't have to hold your certificates in the picture, but it would be nice. And the judges who are still here, it would be great if we could have you on the stage also. Thank you. So this is going to be the last photo. So a few housekeeping things really quickly before we do this. So as soon as we're done here, lunch will be provided for everyone if you just step right outside the room in the back corner classroom. So please join us for lunch. Also, for the winners on stage, please see Carmen, who has been managing the money for OREF, I think, since I was a resident. She needs your address if you want to get paid. I encourage you to see her. And then also, we just want to give a round of applause to the team who put this together. Carmen, Noreen, everyone. Lori Duroff and Katie, and I'm about thanking the family, and thanks to all the AV staff also who helped us have a very smooth day. So thank you guys, all right?